provide a platform for experts to share their knowledge and experiences. Now, I shall request respected Dr. Ramaswamy sir to please come on to the dais for the panel discussion on uncharted territory, navigating unmet needs in relapsed refractory B-cell malignancies. I request respected Dr. Ramaswamy sir. Chaired by Dr. Sharad Damodar sir, Dr. Sajeevan sir, Dr. Sugit sir, Dr. Unni S. Pillai sir, Dr. Sriraj sir. I request Dr. Ramaswamy sir to please come on to the dais.
Good evening all. At the outset, I would like to thank Dr. Neeraj and Dr. Manoj Unni and along with his team and Amrita for giving me this opportunity to be here to share my knowledge. More than that, they are the more expertise as far as the number of patients they have done it, but probably every one of you can give their input so that it can be refined knowledge for us to improve our skills and what we want to do further. So I would like to invite my panelist, Dr. Very well, please. Yeah. Sajeevan. And Dr. Sriraj and Dr. Sharath. Sharath is on the online. Online. Okay, no problem. And Dr. Sriraj is not there. Sriraj? Yeah, so it will be more of a informal discussions only. It's just sharing our views and thoughts. So there is nothing like this is the way that it has to go. The topic for today's discussion is, can I have the slide? Can I have the slide? Yeah, so the topic was given was navigating the unmet needs of B-cell malignancy, relapsed refractory B-cell malignancies. So I will straight away going to the relapsed refractory status of the B-cell malignancies. Next slide, please. Yeah, so we all know this. The particular slide is, all of us are familiar whenever the question of relapsed refractory disease is concerned, and even the same has been reproduced in one of our centers from Tata Memorial by Dr. Vivek Radhakrishnan, that once the BALL is relapsed, the outcome at the end of 5 years is only 20%. Both Western world has also confirmed the same thing. Next slide, please. Next slide. So now, once we have the relapsed refractory status, now what next to be thought about it for a patient? So I would like to ask our panelists to get their views and thoughts, please. Go back, yes, previous, yeah. So we have in the armamentarium some sort of immunotherapy. We know that either the bite or the INA, but both are having a median duration of the remission around 7 to 8 months. So it has to be consolidated. If not, probably a 6 cycles in a case of INA is not yet established. Whereas to be consolidated, whether with a HCT or a CAR-T, why when HCT, why when CAR-T? Probably Sudesh.
Oh, so basically, first I will tell my practice. So I basically represent a government center, and most of this newer molecule, it is very difficult to afford. So our practice is like most of the patient, as we all treat like the first line is BFM. So when they relapse, probably a late relapse, we go for the salvage, mainly hypercivat. So once they attain remission, then we consider them for allogenic transplant, provided a donor is there. That is our standard actually. But now we started using the newer drugs. Definitely we have option of combining mini hypercvad with inotuzumab and or with blina, or even single agent blina. So last patient, Neeraj sir know that we have a common patient where we have the last patient relapsed. Again we tried the hypercvad, patient again had persistent disease. We have given INO, and actually after that, rather than consolidation, he don't have a mass sibling donor. So we are actually planning card for him.
Okay. Unni?
So, in common community practice, it's even tougher to give a BFM, proper BFM, convince them to give a proper BFM, the entire 3-year duration. And unfortunately, if someone relapses, in current Indian scenario, I think most of the patient will end up in a palliative setting. Only a fortunate few will go for salvage therapy, even transplant, CAR-T or newer molecule. That is fact. Even from premier institutes, we get patients, even kids. I mean, when you go, when you measure a community's attitude or a society's attitude towards malignancy and how we treat malignancy, actually reflects how we treat our pediatric leukemia, pediatric malignancy. So, I have at least 3-4 relapsed acute leukemia patients referred from the highest centers in our state for palliative care. Only because I am known to them, I am close to this patient's home, they come to me, and that is what is happening. Only very few of them, fortunate few, go to a higher center, get a salvage therapy. It could be anything. And even if, in my experience, I have I am not doing any allo now. I had done allo during my training period. We were very passionate. We start, probably 10 or 15 patients for allo transplant. We work up them, we condition them, and ultimately we end up having, doing 2 or 3 allos. One of them will die during the process. One of them relapse or die due to, the GVHD or relapse. And like this, 20% will survive. And the struggle which we go through, the family go through, the community goes through is immense, because unlike in the West, everything is self-paid in our society. Nothing is paid by the government. So if the parents can afford, if the family can afford, all these things are good. And if we have done everything, and suppose they spent, say, huge amount of money for an allo transplant, and at the end of the day, if the patient dies in the room or die after the allo transplant due to GVH, it's very tough to face the family after that.
Absolutely.
So this is my experience. And this is, I'm sure this is true, and this is touching for all of us.
Absolutely. It's a lucid narrations of what we are facing on a day-to-day practice. We are currently talking only in the relapsed refractory status, where we are confining around 20% of the pediatrics and 50 to 60% of the adult, where we can give the best possible way. If the financial is not a burden, what way we can do improve. That is what the concern, we are concerned about that. Dr. Sajeev.
Yeah, it's a tough area, everybody knows. But nowadays, if just like you told, like if money is not a concern and we have access to medicines, and these are better options. Traditionally, we have been using Buckingham for allo, if match donor is there, and though it's still there is an unmet need. And these newer molecules like Blinovanbel, I think we have used it on a compassionate ground. My colleague is there, Dr. Krishnan. I think we can involve them also.
Yeah, definitely.
So in a few situations, we have used these molecules, and mostly in children only.
Okay, thank you. So, Dr. Sharath is able to join on the online. He is also one of the panelists. So, Sharath, your view on the BITE or whether based on the number of blasts, pH positivity, even though TOWERS trial has not included the pH positivity as well as the higher blast count, but real world experience has shown both are equally efficacious as far as remission is getting attained. So, in your case, of course, the cost is favoring for the inotuzumab in Indian scenario, but would you like to choose, of course, the CAR-T, if you are considering the BITE will have some sort of issues. So, are you? Yeah, go ahead. Sharath.
Yeah, can you hear me, Ramswamy? So
Yes, exactly.
Yeah, oh, great. Okay. Yeah, no, I think fully agree with the previous panelists of what population we are actually looking at in this subset. It's obviously about 15-20%. It's not the 80% of people who may not be able to afford some of these. So fair enough. But we know that relapsed ALL is otherwise a 0% outcome. And there, if you have a subset of people who would want and can get to do something, even the data and our own Indian data says that you probably plateau somewhere in that 20-25% range as, the survival outcome. Now, clearly, I still believe that the only cure there is a transplant. Even if we go on to get a CAR-T, the CAR-T will get you a remission, but you need to top that up. I think that's a given, for us when we are practicing. So our objective would be you get MRD negativity, and for that you could either do hyper-CVAD, chemo, plus minus combination. A lot of time finances decide that. If it's pH, you could use whichever TKI you want. So very clear objective: get MRD negativity. You achieve that, top up with an allo, and that's your only chance. Is my thought.
Absolutely. That's a lucid information. Anybody in the audience who can chip in and then who can express their views, to have their own views on. Okay, right. So, having said that, we need to achieve MRD negativity. It's a very clear consensus. Whatever the way, whether it is which of the BITE or targeted therapies, either the chemotherapy with or without chemotherapy, whatever the way, if you achieve MRD negativity, the question comes: hematopoietic stem cell transplantation or CAR-T. And of course, at this point of time, the established treatment available, accessible, affordable, probably the stem cell transplantation, and that's what Dr. Sharath mentioned. Is there anything which you would like to ask? CAR-T is preferable over something like that? Okay, so we will go to the next slide, please. So, one of the things, this is being presented in one of the journal Hemisphere by Dr. Short. So, in his, what he was produced, he was trying to see the patient dose dense combination of mini hyper-CVAD with with the blina in a relapsed refractory patient, dose dense, wherein you are incorporating from the beginning induction therapy with the mini hyper-CVAD, incorporate both the molecules, 4 cycles, followed by the inablina, as then even during the maintenance also continued to have the BITE therapy. And the next slide, please. And they found that when the patient achieved the MRD negativity, the transplantation is not made any difference either in the relapse-free survival or overall survival, where there is no CAR-T comes into the picture. There is no stem cell transplantation come into the picture. There is no difference. But bearing the cost, but if you could get it, probably this is also a possibility. That's what we would like to say that. So there are treatment available. It's not that this is the only treatment. But of course, this is in the trial basis, but probably future will tell this are the things, probably. Next slide, please. Next slide. So now coming to the scenario where we may not be able to use the stem cell transplantations, wherein definitely a CAR-T is being preferred, or the CAR-T is preferred in some of the scenarios where it is edge over the transplantations. Probably, Sharath, having experience with that, can you enlighten us on that aspect, wherein the condition where you won't, either the donor is not available or the patient logistic reason that differing, all these things, in that case, where you can think about a CAR-T edge over the hematopoietic stem cell transplant.
Yeah, so I'll give you my honest practical experience, Ramswamy, from the trial data. So, in the ones who could not get a top-up allo, all of them eventually relapsed, So that's the small number, but that's our little experience. So that's why I was, kind of reaffirming that, the allo becomes important here. And just to add to that, the ones who had CAR got MRD negativity and then gone on to an allo, we've actually seen a slightly higher incidence of GBH. I don't know how to explain it, but that's the practical information, So if you don't have a donor at all, will you get away with just a CAR? See, Emily Whitehead is the classic example of that. But in her, you have persistence of CAR even now. And even now she's on immunoglobulin replacement. Okay. Now that I think is an exception rather than the rule. And clearly from whatever I've seen so far, the CAR persistence goes away between day 60 to about day 90 in most people, just honest opinion, So if you do not have persistence, then how will you say that the CAR has actually become curative? I mean, there are a few people who may not have persistence, you're not detecting it, but still in remission. I know there's a small subset, but this is the general thing I'm telling you.
Okay. Dr. Neeraj, you can share your views on thoughts because it's a open forum. So you are all one of the major centers have.
No, so I think our experience is very limited. Maybe I think our first patient got infused in January. So it's about six months only. So we've had, I think we had 4 leukemias, out of which 2 of them have lost B-cell aplasia. I mean, the B-cell aplasia has been lost. The B-cells have already come back in 2 of them. And 2 of them it's persisting. So one patient had already an allo transplant done. So it's a CAR-T after relapse after the allo transplant. So and then if you look at the other thing is only the trial data which I can extrapolate and some product specific and age specific things. So when we look into, I'll be putting that in the panel discussion, but then some of the the initial trial of Eliana, which was less than 25 years, and you saw that the more number of people who didn't get a transplant also had a event-free survival there. So I know the age I think is also a factor. Like when you go older, you have a more need for topping up with a transplant. Looks like that. But I don't know, it's an open question, and when we discuss options, it's more about unknowns that we discuss. But one of the things is like when we have a patient who doesn't have a HLA match, and if you have relapsed and then they are still having active disease or MRD positivity, what do we do with them? Single agent anotuzumab, single agent blinatumomab has not as yet proven to be curative.
It's a median duration around 6
8 months. So what do we do? CAR-T and transplants are given as potentially curative options, but then as Sharat sir said, with longer follow-up, you would know whether these patients who are in remission would then relapse or whether they would need a top-up. So as of now, maybe those who have loss of B-cell aplasia, if they have a transplant option, probably they should go for a transplant as a top-up. But if you look at the first year, which actually Monisha was sharing, that the first year data, you showed that first graph, no? So is that the question is the CAR data better than that?
See, if you see also the CAR data always says 80%, 90% first year, especially for the B-cell ALL. But the story comes after the first year only. Indirect reflex is by the B-cell aplasia where we are. That will give us a hinge whether we are in the right track or not. Anyway, Asmukh Jain is there to give his opinion. Please, Asmukh. I'll come back to you.
Sorry, so thanks. So I think one of the problems this is very contextual. So like for example, in our setting, the problem is that some of the options that you listed are beyond the reach for most of our patients. Cost being one of the factor, but allotransplant is beyond the reach because of the feasibility. So typically less than 5% of our patients actually get a transplant wherever it is indicated. This is across leukemia, lymphoma. Even though the myelomas who get transplanted are practically getting it in maintenance. So we have a different kind of a situation that we deal with. So that is one point. And second is numbers. So the numbers that the academic institutes, like a bigger institute, sees, it's always overwhelming and trying to get everyone through Blina or to be honest, I'm not given a single Blina infusion till date. So it's beyond the reach of our patients. So for us, from a practical point of view, CAR-T becomes one of the important options. That's why it's there on the table all the time. Secondly, I mean, of course, I don't know the answer of what is going to happen at the end of 2 years. That needs time. What has happened, or what I know for now is, out of the 17 patients who were enrolled on the trial, 15 received the infusion, and 60% of them are still progression free at the end of 1 year. So we've just started, we are putting our manuscript together. Last couple of weeks have been just involved in this aspect. But again, I don't think this is, I mean, I cannot say that in a situation where you have both the options available, I cannot say which one is superior to the other, because that will need more data. Outside the trial, we have almost done 20 infusions in the ALL. So this has happened in the last few months. So maybe in a couple of years' time, we'll have a little more our own information on what exactly is happening. Thanks.
Absolutely. Thank you. Anybody else would like to share their expertise?
I just want to share two things, because I had an opportunity to visit the CAR-T unit at Mayo Clinic. So there, as you have mentioned, that the frail and elderly patient, it was mainly in myeloma. So they prefer this, CAR-T is preferred. Even in leukemia, they prefer CAR in the elderly population. Especially in myeloma, definitely all the patients will be by 4 lines failure, it will be elderly. And second thing, in the most of the trials, even if you take lymphoma or leukemia, if for CNS disease, it was an exclusion for all the trials.
Yeah, so you're absolutely, that's why one of the point was that if there is a CNS infiltration, they are preferring the CAR-T because it can go into this one. That is one of the reason that CNS may be edge over this one. But again, said and done, Dr. Ashmukh was saying that the number of patients who are going for the transplant is less because of the non-availability. If you take all the transplant centers, now majority, almost 50% is a haplo transplant because of the utility values, because of the availability of the donor to everyone. So almost now 50 to 60% is a haplo donor. So probably the transplant is still the option. So to sum up, if any more views on thoughts, right? If there is to sum up, as Dr. Sharath mentioned, if there is a MRD negativity, you have to consider the transplant. If there is an MRD positivity, as Dr. Neeraj mentioned, probably you can still think about it. Which one? Definitely MRD positivity with a transplant will have a chance of relapse. So you can consider the CAR-T. Then the question comes post-CAR-T, that we will discuss later. Next slide, please. So we all know that post-CAR-T, persistence of the B-cell aplasia is one of the evidence. Persistence of the T-cells is one of the evidence. Flow MRD negativity is an assurance. But as you know that MD Anderson will always push for the NGS negativity for every treatment, that NGS will be the better choice. So as they have mentioned that if the patient has NGS negativity post-CAR-T, so this is also one of the things to be considered. When you give the CAR-T, probably you do the NGS to prove that the MRD negativity rather than the simple flow MRD. That may give the, even if you see that in the second, that bottom, that on the left side, if you see that B-cell recovery, B-cell aplasia, if the NGS negativity does not make any difference in the outcome. So we know that when the B-cell is recovery, you are expected to have the chance of relapse. But when there is a B-cell recovery, still the NGS is negativity, not the flow MRD, the chance of longer, probably permanent curative option is more. Next slide, please. So in case we have done the transplant, failed, going for the CAR-T, so what are the things, what are the possible ways where probably this is little more this one, probably Sharath, you can throw into the picture when the CAR-T is failed, what are the ways wherein we can salvage it? Still the last resort where you still don't want to give up as you are doing now.
Well, this is a tough one. Most of the time it's end of the road, Ramswamy, to be honest.
Yes.
But theoretically, if you can get a second target antigen CAR, yeah, you could. I mean, this is just talking theory and with data, you know. I don't think that's ever happened.
Absolutely.
But clearly you will have a subset of people who will fail the CAR.
Okay.
And then if somebody is really that affordable, you can bring up a second CAR, you know, which could be a different target there, versus even trying to do a dual at that point in time.
Yeah.
But that's really, you know, just to kind of, for that small subset of patients who you may want to then offer, if that's available, which currently is not there in our country, but again, you know, out of country, all these things exist. I really can't see anything beyond that.
Okay. Dr. Ashmukh, would you throw a light on that? Suppose you have an experience on that. So if it is relapsed after CAR-T, what is your thoughts so that we can learn something? Please mic to Dr.
So limited experience in this context. So only one patient on the trial we reinfused. That's because the patient was still CD19 positive, so had a second dose, and then I mean she's crossed 6 months time point and she's still doing well. But then I don't have much experience on giving a second product in the ALL context. So it is important because 1/3 of them are known to become CD19 negative, and that again we have also seen in the few patients who relapsed. Some of them were CD19 negative, but only if they're CD19 positive, then theoretically there's a possibility of a second infusion. But yeah, I mean, we don't have dual cards yet, so it becomes difficult. And then it depends upon what context. Like it was a first relapse CAR T, for like CAR T earlier, then maybe you could still do salvage and then do a transplant, which we did for one of our patients. So, but options become more and more limited by this point of time.
Okay. Thank you. Next slide, please. So this is the adult ALL trial wherein CAR T is being given, followed by consolidation, autologous stem cell allogeneic transplantation being given or not. There is lot of conflictions. There is no consensus. Some of the university centers are using that consolidation, as Dr. Sharath mentioned, but some centers are not doing that, basing on the persistence of the T-cell, B-cell aplasia and the following the MRD status, whatever these things may be. But whenever, of course, as he has mentioned, that when you consolidate with the stem cell transplantation, already that there is a B-cell aplasia, infection, hypogamma globulinemia, all these things add to the risk of the complications of the post-stem cell transplantation. And of course, as he has mentioned, some of the studies have shown the increased risk of GVHD, but not in all studies. So these things have to be kept in mind. Next slide, please. So, consolidation after CAR T-cell therapy in an adult. In pediatrics, it is not needed, but in an adult, it's a controversial whether the molecular MRD positivity. Suppose if the patient achieved post-CAR T is in remission, but the MRD is still positive, probably at that point of time, will you take it? For a transplant to become successful, we all know that bottom of the line, it should be MRD negativity, but still can be consolidated, whatever the best outcome, if it is persistent. 2, rapid loss of CAR T cells, or whether if the patient is having a P53 with or without complex karyotyping, such patients after the CAR T, can we go for that? I don't know. Ashmukh, can you throw a light? I'm sorry, you are the most experienced persons, and of course, Sharath is there, Neeraj is there to add on to that.
I mean, I'm like, at least from my experience of referring patients with MRD positive to transplants, I've never been able to successfully get them through a transplant and convince a transplanter to do a transplant. So I don't know if that is, I mean, for obvious reasons, because they would also not do so well with allotransplant. So that is a problem that we face if the patient is MRD positive. However, having said that, what we have seen is that post-CAR T, if at all a patient responds, then invariably they are MRD negative. I mean, so it's either it's like an all or none. Either they will not respond at all, or if they respond, then invariably they tend not to be MRD negative, except for a couple of patients who were still MRD positive. But they need some therapy. I mean, what would that therapy be? That's a different question. And second is, there is some data, I mean, it's not like a great data, but there's some data that early loss of B-cell aplasia means that there is impending relapse coming about, and that too in the first 6 months. So that is something which needs to be done. So a lot of things we have not, a lot of these things, a lot of interventions, etc., were not planned in the trial. Some of these things now will happen as we keep treating patients. So this is basically going to take some more time for us to gain experience. Again, I'll agree that if there's a P53 mutation or a complex karyotyping, these patients will perhaps need a consolidative transplant.
Yeah. Sharath, your view on the complex karyotyping and the P53 post-CAR T?
Yeah, this is a subset which is going to do badly with whatever we do, Ramaswamy, you know.
Correct.
So once you have the TP53, even with an allo, you know, the outcomes are dismal. But if you're pushed and you have to do something, clearly having MRD negativity pre-transplant is better than having MRD positivity. Even though in some situations we've attempted even on that with a plan to give, you know, preemptive DLI and make subsequent DLI plans. So it's all nice to talk about, but difficult to do. Now, whether that person you can get MRD negativity with a CAR T, like Hasmukh said, I think the response rates are very good, you know, in ALL. So both, you know, whatever data is there, it's about 90% close to 100% day 28 response, you know. So you will definitely get that CR. The question is the sustenance of it. So that's why you will get a window to top up with something, you know. But in a TP53, even with an allo top up, outcomes are not great.
Okay. So, to sum up in this slide, that P53 is, yeah, Neeraj.
While preparing for the talk, I came across an article in Blood in 2022 where they looked at CAR-T and the different cytogenetic subsets. They have classified it between high risk, and it's a retrospective analysis, but then they looked at high risk, intermediate risk, and low risk cytogenetic defined in, including the complex karyotyping, etc. So, surprisingly, the results were similar across the cytogenetic subgroups. Yeah.
Okay, right. Dr. Monisha, you are one of the part of the pillar of the CAR-T program in Amrita. Please, you have your views.
I would like to agree with Dr. Sharad's view. So this is the subset of patients whom we see they are probably going to do well. So they whatever the treatment may be. So probably considering the toxicity which is associated with transplant, I would like to still go ahead with the CAR-T therapy as first line choice for these kind of patients who come with very poor cytogenetics. So that would be my choice. And post CAR-T, if there is MRD positivity, in this group of patients, a consolidative transplant is unlikely to be beneficial. So that's what I would think.
If MRD negativity,
if MRD
complex karyotyping, CAR-T, MRD negativity.
So MRD negativity, still I would want to give the benefit of doubt to CAR-T and give a follow-up rather than proceed with a transplant.
Thank you for the Neeraj statement that complex karyotyping, there is no difference at this point of time as per the literature available that at 2022. That's a good valid point to be taken into the consideration. So next slide, please. So shifting the paradigm from the leukemia to the lymphomas. So we know that the primary refractory is what point of time, less than 12 months, more than 12 months, chemosensitivity, go for the autologous transplant, and if the patient achieves a remission. Again, the PET-CT score, gray area, up to 3, everybody is comfortable. 4, what to do, whether it is to go for still. So, any views, PET-CT 4 scan 4, dual score 4, what is your plan like?
So basically what we all
Salvage
do,
therapy.
this is same. When patient relapses, whether it is less than 12 months, more than 12 months, for us this make a difference. Because we definitely know within 12 months if the patient relapses, he is going to do bad. Especially primary refractory disease. Whatever treatment we offer them, with the standard available treatment, survival is in months. So the other patient who relapsed, had a late relapse, we do go for salvage chemotherapy and do an autologous bone marrow transplant. For that part, there is no confusion. So less than 12 months, even though we do the same thing, now we know that the results are very poor. And definitely when there is an option of CAR-T, we have to, if there is an option, definitely we have to go for CAR-T, especially when relapse within 12 months. Because the response rate in most of the trials, it is 70 to 80%. But as for all other CAR-T, after 2-year BFS, if you see, it is coming down to less than 40%. So even with CAR-T, the survival is said to be that the cure rate is said to be less than 20%.
Absolutely. Dr. Unni.
So I agree with Dr. Sugit. But our approach to relapsed lymphoma seems to be much more positive compared to someone with a relapsed ALL. Generally, that is true. And we are all enthusiastic, and we end up, most of the patients end up getting some form of second line therapy. So that is the positive aspect of lymphoma compared to leukemia. And compared to the score of 3 versus 4, the problem what we face is that the score 3 and 4, which the Europeans and Americans report, are uniformly same because they have standardized their protocols. They have standardized their institutions across Europe and US. Here, something may be 3 in my institute, someone may report the same as 4 in some other place.
Keeping this as a standardized.
So, the standard of PET-CT reporting is, to be honest, is very poor in India. In most of the centers, I won't say in all centers, in most of the places, there is no standardization. So, and all the 3 which I have seen end up in a relapse at some point of time. So that is my understanding. So with that, and I would like to add one more point to the earlier ALL discussion. So whatever we discuss on an CAR-T which is available today, so a better generations of CAR-Ts are in the pipeline and they are coming. And we are very hopeful that those CAR-Ts will come and replace, at least offer cure for at least majority of our relapsed ALL patients, B-ALL patients. Because this is an area where there is a huge unmet need. I know that the cost is very, very high, but if it's available to the masses, the cost will come down. That is my hope.
Sajeev.
Yeah. When somebody relapses after 1 year, we were at least hopeful more of a comfort zone because you have the option to induce with the second line, so many options. And if they achieve a good response, and traditionally we have been doing, even now we are doing a transplant. But the other end, we have an opportunity, window has opened now. So the refractory disease or the early failures, definitely, if there is an option to go for a CAR-T, we may offer them, especially if you have a clinical trial to find out. And this PET score 3, we generally don't do anything. We'll keep them on follow-up only. And if there is a provision 4 definitely we may offer a biopsy. That's what practically most of us do. Like anything else?
Sharath, your view on the PET4, whether you will go for a CAR-T or whether your biopsy proven or something like that. It has come down from 5 new lesion to 4, gray zone.
Yeah, you would want to biopsy that if it's 4 at least, for me, to be fair, because you don't be sitting in progression of disease. So certainly we would intervene there. The 3 will probably wait if it's a clear-cut 3. But again, I think if you've crossed 1 year, you're chemosensitive, so you still have a chance that some salvage will work. And if you've achieved the CR with salvage, then obviously the auto is clearly the favorite there, considering the cost also there. But I think the largest subset which tends to relapse within that first year, which may not be really chemosensitive, is a subset which will truly benefit from the CAR at this point in time. And even, saying about a 40-50% long-term response rate with the data so far, I think that looks better than the auto for that subset of patients. So that's the point.
Okay. Mobilization failure. Will you consider the auto, allo transplant or the CAR-T? Mobilization failure, instant remission. Let us say that after 1 year, patient achieved remission, but there is mobilization failure.
CAR,
allo or CAR?
CAR. Allo has its own huge set of problems, so CAR surely.
Okay, right. Asmukh, your views. CAR.
I agree. So less than 12 months, yes, CAR T-cell therapy. Beyond 2 months.
More than 12 months. But achieved remission.
CAR T-cell therapy. Yeah.
CAR-T. Anybody? Go ahead.
A slight difference which I would have in this context. There's a CIBMT registry data which shows that within 1 year, if there is somebody who is in at least PET PR or CR, they have a 40% long-term EFS with auto. So, and we also sometimes do offer auto to those who have chemosensitive relapses even within the 12 months. And the CAR-Ts actually are very, very, product specific. So if you look at the US CAR-Ts, you would have something different going on with Axi and Brexu versus TISA. And, Axi, Brexu in this context, within 1 year, they do well and they have, succeeded in their RCTs, but TISA did not. So there is a difference between the products. So we can't extrapolate the data from one product to another. And we should probably, for the time being, because we are still following up and we are understanding these cells better, I think we could slightly be more, choosy, and we could choose wisely on transplant versus CAR-T. As of now, we don't need to go all out for CAR-Ts for every kind of POD12.
Absolutely. Anybody else? Go ahead.
I just wanted to ask, very curious. So even if you're trying to do CAR-T, you still have to bring in remission and then do the CAR-T. Is it necessary or no?
Not necessary. That's what the coming slide is going to.
That is not necessary, but still, if you have a high tumor burden, metabolic tumor volume, your responses and your durability of the responses are likely to be affected by that. So you would want as low disease burden as possible, but what happens while doing that, there may be some situations when you actually achieve a CR. If you look at the Juliet data, there are 7 patients who were in CR, were taken up for CAR-T and were taken off protocol. So there is a problem there because there's some patients who will actually achieve CR with your POLA-based combination or something, and then you're going to wonder, now my patient in CR, and I've done the leukapheresis or whatever, I'm planning it, and then you would have to choose between the two or maybe go it with the CAR-T. That's going to be a difficult thing to understand as of now. I have had that situation already.
Okay.
I've faced it. In fact, there is one patient who achieved a near CR with acalabrutinib. And, I still went ahead and gave the CAR-T. The response deepened further. And, it's very difficult to be sure that CAR-T is giving us the response. All the durability will tell us, and the recent ASH data, the outcome for those who are in CR and have been given CAR-T is very similar to those actually who are not in CR. It's at about 40-50%. And this is the recent ASH update. It's a pooled data, registry data again.
Yeah. So as Dr. Prashant mentioned, let it be 1 year. If you are able to achieve with the salvage, platinum, which you never exposed, chances are less likely. But still, if they achieve, you still have the story for the transplant, autologous consolidation. Still, you can consider, of course, outcome may be differ, outcome may, but still. Similarly, if there is a score 4, whether to take it or not, available, you give it. It's not 50% as you expect, but it may be a 30%. But still, that 30% is utilizing values with a lesser cost, with available treatment, accessible treatment. You can consider if the stage 4 where there is no CAR-T is not freely, of course. But because of the luck, we have Immuno Act to get the things done fast. But still, if you are not able to get it, probably you can consider. Now the question comes. Now the question comes that if the mobilization failure, that is whether to go for the CAR-T, I will for the stem cell transplantation, allo transplantation, why not? Of course, for that. Next slide, please. So now, allo or the CAR-T, which one to choose? Probably, let us say that if there is a mobilization failure or whatever the reason. Next slide, please. So, post-allogenic stem cell transplantation, which is one of the clinical options up to 2018 before approval of the CAR-T. Overall survival rate varies from the pooled data 12 to 80%. PFS varies from 30 to 80%. Non-relapse mortality varies from 10 to 55%. You take it average 25%. Acute GVHD, chronic GVHD, as in the mention in the data. But in the CIBMT data, 3-year PFS is 30% and overall survival is 37%. And of course, it depends upon the various factors, disease at the time, and then the conditioning regimen, what is the donor, whatever other things may be. Come to the next slide, please. As Dr. Prashant mentioned that Zuma, Juliet, Transcend, based on the various eligibility criteria, depends upon the which CAR-T you are included. Keeping aside the various factors of the prognostication for the CAR-T outcome, if you see the overall response rate is around 50 to 74%, CR rate is 40 to 54%, 40% who are refractory to the CAR-T still living at around 3 to 4 years. Here the point to be considered, go to the next slide please. So, there is no difference actually if you see that, but the non-relapse mortality in case of allo transplant goes up to 55% if you take it around for 25%, whereas non-relapse mortality because of the CAR-T is only 4 to 5%, keeping aside the cost. I'm not talking about the financial. So what they are telling is 2000 to 2004 to 18 in EBMT guidelines says allo is an option. Now 2018 when the CAR-T is getting approved, it is a standard of care in a patient who is not in. As one of the questions Dr. Chepsi was asking, if the patient went to go for the before that CAR-T or the allo, you can see the last, the bottom of the line, the second bottom, CR/PR in CAR-T only 25% to 26% have achieved when they before going for the CAR-T. Whereas allo you are mandatory to have a 80%. So something you are doing it to get into the achieving the best success for the allo transplantation with the various transplant or TBI, whatever the regimen may be. So in such patients, and again the P53 as like in the case of ALL is coming into the picture. So at present the EBMT guideline says that CAR-T is the standard when the patient primary refractory or not achieving the remissions or post-autologous transplant relapse and other things. Next slide. So this is the busy slide, but to sum up, Dr. Sajeevan, so how will you approach the relapsed BLCL just for the completion sake?
So with this, maybe in this era, in this latest guideline, maybe this is because if you are not achieving I think remission, I mean, primary refractory disease or early failure, and if you have the facility for CAR T-cell because it's approved therapy, when all the guidelines and FDA is approved, if you have the option, you may go for it. And of course, if that is not possible, still you will be trying with your second line remissions and this thing. Second line protocols and try to go for transplant if it is in remission. If it is not in remission, still it's a big question. So that is the thing. Anything else you want to add on?
Anybody else? Dr. Sharath? Summing up.
Thing for us, Ramswamy, to be honest. So I think clearly, CAR is where people would go to. Allo in lymphoma is practically tough, and you've shown the data for that also. The TRMs are so high, and the complications are so high. So I really don't think it comes into the algorithm per se, unless you have nothing else. But other than that, I agree with whatever else was discussed.
Okay. So CAR-T is the road. Okay. Next slide, please. So this is the in front of the instead of the busy slide, it is the same sum up what we have done it. In a late relapse, transplant candidate, if you achieve the remission, probably go for the consolidation autologous. Non-transplant candidate, you can consider any of these things. And if the primary refractory or early relapse CAR-T candidate, you go for the non-CAR-T candidate. There are various options available, Pola-BR, tafasitamab or R-Gemax, which we are routinely using it. Next slide, please. So this is when the CAR-T failed in a case of lymphoma, what next? So the bispecific antibodies are coming up in a big way. Fortunately, we don't have to hit our head, hard in our head because it is not available in India. Till then, we can relax without knowing all these things. Next slide, please. So if the prior CAR-T therapy is received and the patient failed, so relapse within the 3 months, you can consider one of these possibilities. Yes means bispecific antibodies can be considered. How long? Continue till the response. There also they are showing a good reasonable amount of the response, an average of 1.4 months as like CAR-T you are getting the response, and the duration response is also around 50% as like that of the CAR-T who has failed in the CAR-T. But only thing is the treatment has to be continued till you lose the benefit or the toxicity occurs, that sort of things. And again, the trial is if there is a CD19 is expressed or not expressed based on the bispecific antibodies or tafasitamab, if there is a CD19 is being expressed, can be considered. So next slide. There's various data available for the CAR-T failed patients. Next slide, please. This is also the bispecific antibodies with the various data. Next slide. And of course, autologous CAR-T. The time taken and the availability issues and the T-cell because of the defective T-cell either by the therapy or other things, allo can circumvent that, but at the expense of the GVHD, which we all know that. With this, I am closing it, and probably the floor is open for the discussions, opinions. Yes, Prashant.
I just share my experience of post-CAR-T relapses. So I have dosed 5 DLBCL patients, and of those 5, 3 relapsed. And the first 2 relapsed, I gave them glofitamab, a compassionate access. None of those responded. They still survived. One survived 1 year beyond the CAR-T, and one survived for about 6 months. And again got glofitamab, no response, PD, and was not fit for any chemotherapy after that because both of these patients were post 6 and 7 lines of treatment already. And the third patient who was primary refractory to R-CHOP, she was on bridging. As a bridge I gave Acala, and Acala-Len I usually use as bridging very commonly, especially in the ABC subtype. And then this patient got the CAR-T, and day 30 was a PR, and about day 90 or before that was a PD, and this was again the Acteli cell. And after that I did have some experience that glofitamab was not working for my patients. I already had 4 glofita failures by then. And then I said, okay, I looked at some European data, glofita plus Pola. And Pola launch, had been launched by then and was working fine. So I combined the two. I gave Pola glofitamab, and this is the only patient I have been able to salvage. And she's in CR. Now she got the infusion in December end, and now she's in CR. She also interestingly had delayed ICANS and severe ICANS. She got comatose just after obinutuzumab before I started the glofita. And 2 days later she was comatose, and at late night I gave her methylpred, and morning she woke up. I shared with Hasmukh also that I can't understand why such late ICANS is happening. Then I dig the literature. There is a reported ICANS day 113 of CAR-T. And this patient is now doing very well actually, and in CR, and continuing the Pola glofita. I'm not stopping it. I'm going to complete it.
Yeah. So same experience to me also. Patient has received a CAR-T outside. They came with that, and we have given a glofitamab. We got the medicine compassionate basis. He didn't respond. 3 cycles we gave it. Probably rather than that, it is due to the CAR-T. It may be a glofitamab itself. As that is why we are saturating the site of CD20 by giving a obinutuzumab on day 1 of the glofitamab. So probably it is because of the molecule rather than because of the past CAR-T, maybe they expect. But glofitamab, but they are telling the data is showing a 50% by 1.5 months is the response. But I am not getting, but of course, you are more experienced of 5 patients, 1 patient, I cannot say anything. Just ask me.
No, just to add to this, yeah, so a lot of our patients also post-CAR-T have got glofitamab, and it's not been as per what is reported in the literature. I mean, I think overall this is actually a little disorder situation which is full of disappointment, to be honest. But glofitamab per se, the reported 12-month PFS is 37%, and this includes some of the patients post-CAR-T. In my own experience, no, hardly have had a response. The only a couple of patients who responded with mantle cell lymphoma patients and 1 follicular lymphoma. These 3 responded. But consistently in the DLBCL patients, I've seen hardly any response, maybe 2 partial responders who progressed. But again, I kind of agree with Prashant. This data with polatuzumab, glofitamab is quite exciting. And they reported 80% responses, 60% CRs. So as a strategy, we have started using that as a bridge, because giving it for 6 months is again a difficult challenge. But as a bridge, we have started using at the dose level 1. So essentially, Pola 1.8 and then 2.5 glofit and 10 glofit, so stop at that. And I don't know whether it's a beginner's luck, but all the first 4 patients whom I've given, they've all had at least a partial response before the infusion. I mean, again, this is something which we'll have to see how this strategy helps, but this is something which looks very promising.
Yeah, definitely. But even the Pola single agent is not worked very well. It has been shown very clearly in the data that it's a combination. What is that combination? In the setting of the CAR-T, the combination is doing well, even though single agent is projecting well, but I don't know whether it is working in the long term. We have to see that. Of course. Even otherwise, Pola BR also can be considered once that is being failed, that if they are not received before, probably. So, if there is none, I would like to thank my panelists. Thanks, Sharath, for giving your valuable input. I'm not able to hear. Muted.
Now.
Yes.
Yeah. So one final note on that, just to add to what both Hasmukh and Prashant said. So again, one patient who's relapsed post-CAR. So, gave Pola R CHP, not much happening, but doing well on Pola R ICE now, and awaiting the glofitamab. So it was nice to hear that combo seems to work better. And then clearly now the patient is asking me, okay, you get me into remission. Will you allow me after this? So what will you do? So that's the difficult question to answer now, I think, which some of us will have to face.
Post-CAR-T, when the patients are undergoing, as like in the discussion in the leukemia, cytopenias, the hypogammaglobulinemia, GVHT high, all these things you have to expect, which will be, and still around 20% you can salvage it. The routine complications of HSCT, on the top of this, all these things you have to keep it in mind. Anything else? Anybody else views? Thank you, Neeraj, for giving me this opportunity. Thanks, panelists, for joining us.
Thank you.
Hasmukh Jain, sir, the speaker. who is Associate Professor of Tata Medical Institute, Mumbai, for the topic on T-Cell Therapy in India, lessons learned from clinical trials and real-world data for relapsed refractory B-cell malignancies. Chaired by Dr. Pawan Sir, Assistant Professor of Department of Medical Oncology and Stem Cell Transplant, Basavatarkam Indo-American Hospital, and Dr. Sudeep Sir, Consultant of Hematology and BMT Astor Hospital, Calicut, and Dr. Chipsy C. Phillips Sir, Professor and Program Director for the Department of Hematology and Stem Cell Transplant, Believers Church Hospital, Tiruvalla, and Dr. Deepak Chalis Sir, Consultant Hematology and Hemato-Oncology. Please come on to the dais, sir.
at Hyderabad when I was talking about lessons learned. He skipped it for the India-South Africa final match. So anyway, I've got you here. So we will, I will share the lessons which we have learned on the trial and also what we have learned from the other settings. Just waiting for the slides to come up. So this is my conflicts of interest. So this cell therapy journey has started. I mean, it started actually way back in 90s, where people were trying to engineer T cells and trying to make them work against cancer. But I think the real success after the first generation was actually with the second generation, when the second generation cars were successfully manufactured. So somewhere around here, and then the first patient got dosed in 2010. So actually, it's still very early days in the whole history of CAR T-cell therapy. The only difference this time is that usually when a new therapy is developed elsewhere, we just hear about it, we just like listen at EBMT, at ASH, at EHA, and we just wait for the molecule to come to reach us. But it's I think first time in Hemonc where we've had the first approval in 2017 in the West, and in 2023, I mean, in a relatively short time, we also have access to this molecule. So that's kind of interesting. So what I'm just basically going to cover is whom to give CAR T-cell therapy, what are the salvage and bridging holding therapy. So essentially whole discussion of what therapy to give at what point of time, these terminologies which are being used. What is the supportive care? I mean, that is, I think, probably what we have learned more about how to handle this therapy. A bit on post-CAR T-cell therapy monitoring, a bit on post-CAR T-cell therapy intervention. A lot of this has been discussed, but I just try to summarize here. First is whom to give CAR T-cell therapy, and I know there's a talk coming up, so I'll keep it crisp. This is what we do in the practice. It may not be exactly what is the standard of care or standard of care in the West, but this is what we are doing right now. Is if you have a relapsed refractory DLBCL, the simple question that we ask is this refractory or is it a relapse within 12 months? If so, then the preference is to give a CAR T-cell therapy. If no, then it's salvage followed by transplant, and then CAR T-cell therapy only comes into the picture if the patient if there's no feasibility of doing a transplant. Of course, when considering CAR T-cell therapy, what is known is if you do earlier, it's better because your T-cell fitness is better, T-cell quality is better. This is bulk is an important point which was discussed earlier, whether it is metabolic tumor volume or whether you're just looking at the size of the tumor. And again, exposure to bendamustine becomes a problem. So that is something which consistently we have noticed is a problem. Why I say this is because of some of these phase 2 trials initially which heightened the promise and which showed that about 40% of the patients, 30 to 40% of patients, depending upon which paper you're reading, with 3 different products, all directed towards CD19, there was durable responses in a population where otherwise, historically, there were hardly any long-term responders. In fact, the median survival itself is 6 months. Then this was then followed up by these phase 3 trials, and again, 2 of them were successful. That is with Axicel and with Axicel, the Zuma-7 trial, and also the Transform trial, the Lysocell, whereas the Belinda trial was a negative trial. The key finding here was there was an improvement in the EFS, and also the long-term follow-up of Zuma-7 was published, which showed that there was an improvement in the OS as well. Reasons why there could be a discrepancy, there are certain reasons which have been pointed out. We don't know for sure what is the problem, but the way EFS was defined itself was different between the trials, the timing of the definition. So, for instance, many of the patients on the Belinda trial had actually progressed even before they got the CAR T-cell therapy, accounting for some of the events. Vein to vein time has been an important problem. So in Axicel, generally, when you see even the Zuma-1 and the Zuma-7, the average vein to vein time is actually shorter. It's 29 days. Now, whether because of that they don't use, or is it because of better patient selection, difficult to say, but they just allow steroids as a bridging therapy. Whereas if you look at the other 2 products, that is Lysocell and T-Cell, they generally allow for a bridging therapy, and most of these patients will require bridging therapy. From my own experience, and I'm sure it will be similar with others as well, then many of these patients will require bridging therapy. It's very difficult to keep them going, even if it is a matter of 3 to 4 weeks without bridging therapy. But the other important difference why perhaps Belinda was a failure was the long vein to vein time. It was close to 2 months. Again, very difficult to keep these patients going like that. So anyway, the Zuma-7 showed that clearly there was a difference in terms of second line setting treatment. So Axicel clearly showed an improvement in the EFS as compared to standard of care, which is salvage chemotherapy followed by transplant where feasible. Right, so the second problem was ALL, and in relapsed refractory ALL, what we do is now we look at CD19 expression, we look at the CD22 expression, we look at pH status and the CSF status. Typically, how this helps us in selecting a salvage regimen. So if what we do right now is that if you have a CD22 expressing ALL, then we give a salvage regimen which is preferably a mini hyper CVD with inotuzumab. If the patient is pH positive, then we just give either ponatinib with inotuzumab, just one cycle, or just ponatinib alone as one cycle. The idea being just to get the disease burden down. Once the disease burden comes down, that is when we do apheresis. So we generally don't do apheresis at this point of time. And then we give a T-Cell therapy with an intention to do an allotransplant. In a low disease burden, so if the patient's disease burden has come down at this point of time, then we do a T-Cell therapy and then we closely monitor them. This is also by default rather than by design in some instances because of our low transplant rates as it is. Okay. So why we do this is because of the systematic review and meta-analysis of about 1,000 plus patients, where what they showed was this is a mixed bag of patients who were treated with different products. And again, the consolidation allotransplant was was used very heterogeneously, but less than 25% of these patients underwent a consolidative allotransplant. They showed that there was durability in terms of remission. And importantly, the important factor which was influencing this remission was the morphological disease. So if your morphological disease was low, you had a higher chance of durability in terms of response. The other factors being the conditioning regimen used. So that way, that is the reason why if the disease burden comes down, then we tend to just use T-Cell therapy and then monitor them for loss of B-cell aplasia. Now, the other indications where T-Cell therapy is used is indolent lymphoma and mantle cell lymphoma. Now, in practicality, many of these patients actually don't come, but the results are perhaps better in these lymphomas as compared to the high-grade lymphomas. Particularly, I'm sorry. So the patients who are destined to do poorly, that is patients who have failed 2 lines of therapy, particularly those who have a progression within 24 months, so these kind of patients, and mantle cell lymphoma who have at least failed 1 line of therapy, but they are either exposed to BTK inhibitor or if it's not feasible. So this is the data I've shown here. This is the summary of the 3 trials of follicular lymphoma. These are phase 2 trials, but quite a good number of patients, and they've showed that there's durability of response. And this is the data in mantle cell lymphoma. This is a cohort of patients, relapsed refractory, and this is probably some of the best responses seen in this setting with any form of therapy. Yeah. Now the question is, which now we have been discussing a lot, is off-label use. Now this is not something which we have done on the trial, so we are looking at the other groups and what they have done outside the trial, because a lot of these questions come up. So first common thing is CNS lymphoma. This CNS involvement to give CAR-T or not to give CAR-T. We don't have an answer because we did not treat such patients on the trial. Now we are doing this outside the trial more and more. But there's already some experience of about 128 patients which is published where a combination of primary CNS as well as secondary CNS lymphoma patients were treated. This is with T-Cell as well as Axis-cell, keeping in mind that these products will have neurotoxicity even otherwise, even in the absence of CNS disease in about 20 to 25%, that is grade 3, grade 4 toxicities. So this was even more interesting that the CRs were similar, but there was no increase in the neurotoxicity, or it was actually comparable to what was seen in the non-CNS setting. The second problem that we see now is ALL extramedullary disease. So you have a patient treated, has relapsed in the extramedullary sites, either as isolated or concurrent with the narrow disease. This experience even globally is very limited. This is one such experience I'm showing here from the NIH group, where they looked at a bunch of patients who had both isolated as well as combined combined extramedullary disease. So they followed a strategy where they would do a PET-CT scan for all of these patients, and they found that about 18 to 20% of these patients had extramedullary disease. They gave T-Cell therapy, and they showed that there were some responses here as well. But this is all something which we will get to know only as we treat more patients. Now the third graph here is actually a group of patients who are elderly, because one of the other question is how old, so to what extent can you go, what age can you go, and keeping in mind that generally 60-65 is where you draw the line for auto transplants. But for the T-Cell therapy, theoretically there's a possibility that if the patient is fit, you could give it even in the elderly patients. So this data shows that the responses are similar in the elderly patients as well. And this also actually looked at the presence of comorbidities, and they said that there was an increase in the comorbidity if the patient had liver dysfunction, particularly the child took B and C, if the patient had renal dysfunction and the creatinine clearance is less than 30, or if the ejection fraction is less than 45%. But the responses were similar. We really were just learning on this. So our oldest patient whom we have treated so far is 74. That was outside the trial. On the trial, it was 71. We just have a patient lined up who's for therapy aged 83. So the oldest patient whom we have treated. Of course, these are not things that we would, these are not the patients whom we will consider for auto transplant, but yes, this is still something which we are learning. So just to illustrate a couple of case scenarios on which kind of patients probably will benefit, and I think there's nothing surprising here, but just to share our experience. So we had this patient on the trial, 30-year-old lady, dentist, DLBCL, 6 cycles of R-CHOP, had a CR, had an early relapse, and the disease was in the lung and the iliac nodes, non-bulky. So she was on the trial. We gave her CAR-T 11 million cells per kg body weight, which is close to our, 10 million cells is where we see a lot of efficacy in the DLBL. So she attained a CR. She's on follow-up and she's completed month 15. Post-infusion course, of course, was complicated by hypogammaglobulinemia. She had tuberculosis around the month 12. This is again something which is important to keep in mind. There's a T-cell deficiency which is being induced. So particularly in our setting, we'll have to be cognizant that we will have to monitor these patients for these kind of infections. She requires intermittently IVIG. She's doing well and she's resumed her work. So I think the point here I'm trying to highlight is that first-line failure, low disease burden was probably something which led to a better response. Likewise, in this young patient, 25-year-old, who was DLBL primary refractory. So after 4 cycles on treatment progression, we did an apheresis. We bridged with 1 cycle of GDP. He caught COVID. This was middle of the pandemic, so it got delayed. The infusion got delayed, but eventually he got the product after receiving only 1 cycle of GDP as a bridge. And he's on follow-up and his cross is 24 months. So he's the longest survivor on this program, and he remains in CR without any further therapy, doing well. Now he did not have any hypogammaglobulinemia, did not require any IVIG replacement, did not have any CRS, and he's of course not on any medication, and recently he just fathered a baby. So yeah, of course this is important. Whom not to treat also is important. Why metabolic tumor volume is important, why bulk is important, why lines of therapy is important is you're taking patients in a T-cell exhausted state, you're giving them therapy with the complex microenvironment. So there is a low chance that CAR T-cell therapies will work. Now this is one patient who was on the trial, one of the earliest patients, actually on the phase 1 trial. He had a left hemifacial lesion, and these are the kind of patients who were being referred to us initially. And patients who had exhausted multiple lines of therapy, had progressive disease. Now, when he came to us, he did not have a big extra, he had a smaller cutaneous lesion, and we thought to bridge him with milder chemotherapies, as was the thinking then. So we put him back on oral methotrexate. We did his apheresis, and then he went back to his local place. He caught an infection. He could not come back to us for almost 6 weeks. Now, by the time he came to us, it was like this. Theoretically, they still remained the patient eligible for infusion on the trial, got the therapy, did not do well. In fact, had a progressive disease post-therapy, was on best supportive care, had a COVID infection, eventually died because of COVID pneumonia. So I think that was the important message, and the impact of comorbidities I've already highlighted. These are the group of patients who will have more toxicity, so we'll have to be careful about them. But this is again product dependent to a large extent. So particularly some of the complications like CRS and ICANS with the humanized products is lower. So here I'm showing the data of CRS in the lymphoma cohort and in the leukemia cohort, and this is a comparison. So this blue is essentially the data with Actalicel. So the milder forms of CRS is common, whereas the severe form of CRS is actually less common, particularly in the lymphoma. In the leukemia, it all looks the same. So in the lymphoma cohort, irrespective of the disease burden, the CRS tends to be low with the humanized products, and the neurotoxicity. So the neurotoxicity is absent. So that's another important feature which makes it easier to deliver these therapies. So if you look at leukemia or lymphoma, grade 3, grade 4 neurotoxicity is about 20% of the patients will have neurotoxicity with the murine products, which is not seen with the humanized product. So that's something which is helpful. So that's so much about the first thing, and this translates into a lower need for ICU care because of the lower toxicities. So the next question is the salvage therapy, bridging therapy, holding therapy. So the difference being salvage therapy is where you're trying to actively reduce the disease burden. Bridging therapy is where you are, I mean, holding therapy is before that. So holding therapy is where you know that you're waiting for a manufacturing slot, you're trying to just keep the disease, the patient going, keep the symptoms under control. The same thing is also with the bridging therapy, but bridging is once you've done the apheresis and while you're waiting for the manufacturing. So in sense, bridging and holding therapies are more or less the same, but salvage therapies are where you're actually actively trying to get the disease burden down. I mean, it's been, the thinking has been that it's not necessary to give salvage therapies when you're using CAR T-cell therapy, whether it's lymphoma or leukemia, but it probably will change, I think, because this is a summary table of what responses you would expect with the different bridging therapy options available for lymphoma. Now, the options are you can either use platinum-based regimen, you can use polatuzumab-based regimen, pola alone, pola rituximab, or pola BR. So the point is that whatever you use, the responses are almost similar. It's about in the range of 40 to 45%. So if the responses are not going to be great, then the idea is that don't use something which is very toxic. So you don't want to delay an effective therapy. So you want to just keep the disease going. So therefore there is a more inclination towards using something like a pola rituximab. But what we were discussing earlier is that though general consensus is that it's not important, but there is some data now. There's this analysis of almost 400 patients who were treated with CAR T-cell therapy, and they've looked at different bridging therapy options that were used. And what they showed is that whatever bridging therapy you use, if you're attaining a stable disease or a partial disease, versus if you have a CR or a PR, so if you have a responding disease, your outcomes are going to be likely better post CAR T-cell therapy. So there is a tendency, or there's a move towards now using some sort of a salvage therapy to try to get the disease burden down. And in that context, this becomes very interesting. And these are the 4 cases that I was talking about earlier. These patients are difficult, relapse refractory. Like this patient is a primary, so 3 of them actually primary mediastinal B-cell lymphomas. So this patient had failed 3 lines of therapy, last one being brentuximab, pembrolizumab. Gave 1 cycle of pola glofitamab. This is what has happened. This is another patient of primary mediastinal B-cell lymphoma, failed 2 lines of therapy, and this one had failed 3 lines of therapy, last one being nivolumab. This is the only patient who had DLBCL, double expressor lymphoma, double hit lymphoma, sorry, failed on R-epoch and had significant disease burden, again with 1 cycle, this came down. So without an increase in the toxicities. So that is something which probably will change as we go along, that if you have a therapy which is not very myelosuppressive, maybe this could be a good strategy to at least get the disease burden down and then go ahead with the CAR T-cell therapy. Now the other question is, what do you do when patient is in CR after bridging therapy? This is likely to happen. If you're going to use pola glofitamab, this is going to happen probably in 60% of the patients. Whereas even now in a certain number of patients, this will happen. So this has been also studied. So one of the concern is that if you have attained a CR and if you don't have CD19 tumor antigen for the stimulation, will the CAR really expand? And this there are several such analyses, but this one I've shown here is analysis from 8 academic centers in Spain. They looked at those patients who had a CR before the infusion of CAR T-cell therapy. What they showed was the toxicities were low, the responses were better, and there was also CAR expansion, just like you would expect in a patient with an active disease. So therefore, giving credence to the fact that you could still use CAR T-cell therapy. Now this is the CIBMTR data which Prashant was earlier mentioning, which has shown that so this is a retrospective analysis, 2 different cohorts, 2 different eras, patients treated on patients planned for auto-transplant, patients planned for CAR T-cell therapy. So if you had a patient with the salvage therapy and attaining a CR or PR, they looked at the differences. There was some improvement. It appeared that there's an improvement in the PFS with auto-transplant as opposed to CAR T-cell therapy, but keeping in mind that this is different cohorts. So the median lines of therapy in the auto-transplant arm was 2, whereas in the CAR T-cell therapy arm was 3. The disease characteristics were also different. So, we cannot clearly say that this one is superior to another, but really we don't have good evidence to say which one is better. Sorry. So sorry. So what is the impact? This is another important question about selection of patient and about the use of salvage therapy. So one of the things that is very important is, particularly in the context of DLBCL, I think when we feel that CAR T-cell therapy is going to be one of the options, then avoiding bendamustine, because bendamustine tends to, and we know this from the transplant experience already, that it will affect the T-cell fitness. The only patients where we have failed in terms of manufacturing have been the patients who have been exposed to bendamustine. So, and this is clearly now also established that this is actually a cohort of mantle cell lymphoma patients where they looked at what happens to patients who were not exposed to bendamustine versus exposed to bendamustine, and the cutoff is as high as 9 months. So even if you have got bendamustine, you've been exposed to bendamustine within the preceding 9 months, the manufacturing failure goes up. And not only that, even if you get a product, the responses and the durability of responses is actually inferior. Probably trying to show that the T-cell quality is actually inferior even if you get the product right. So I think bendamustine becomes important. And now in the ALL context, what is important is, I think one of the most effective therapy, which is non-myelosuppressive that we have in our hands, is inotuzumab. And an inotuzumab combination with mini hypersensitivity doesn't seem to increase the toxicity. It is a practical strategy for us because it reduces the requirement of inotuzumab. So the number of vials required actually goes down. So that way also it has become one of the most useful strategy, practical strategy for us. But the concern was that if you use inotuzumab as a salvage, will it hamper the quality of T cells that you collect? But there are at least a couple of studies which have been presented at least at meetings, and this is one which was from the NIH group. And what they saw is that even if you're exposed to inotuzumab, the T cell quality did not go down, and there's a wide range of time before which the patient was exposed, starting from as short as 3 weeks before the infusion to as long as 6 to 7 weeks. So inotuzumab does not seem to hamper the T cell quality, and you can still get a product and still take the patient for CAR T cell therapy. So the third important thing that I would want to say, and this is something which is more personalized, which is something which is may not be there, all of this may not be there in the literature, but what we learned is about the supportive care aspect. So some of the key supportive care complication is cytokine release syndrome. So what we've learned is that cytokine release syndrome, more common in leukemia than in lymphoma, tends to be more severe in leukemia. And in the leukemia also, it is related to the disease burden. So if your disease burden is high, if you're taking the patient with frank disease, then it tends to be early. So as early as few hours, so you give CAR T cells and in a couple of hours you start seeing fever. And it tends to be more severe. So the grade 3 grade 4 CRS that we have seen has only been in this setting where the patient has frank disease, we have given CAR T cells, and then they have grade 3 grade 4 requiring inotropes, steroids and TOSI. The second point was about IC hemophagocytic syndrome. This is something which is reported, is also seen with about 5 to 6% of our patients. It's very important to understand that, realize that ICHS is different from the conventional HLH, where fever may or may not be a prominent symptom. It is more relying on cytopenia. So if you have a setting where there's persistence of cytopenias or there's a reappearance of cytopenias, particularly with a rising ferritin, this is something which has to be always kept in mind. And it usually follows CRS. So you've had a CRS, it will either follow CRS or there'll be a few days and then again you'll have cytopenias coming up, and that is when you suspect ICHS. And I'll show a couple of cases. First, I'll show what I was trying to emphasize. And this is incidentally what happened was we had 2 rooms and 2 patients getting treated parallelly, one with a high disease burden, one with a low disease burden. That was, I said, was a classical way of understanding what is the difference. So the patient to the left is a young boy, 15-year-old. He had relapsed on maintenance, and on the trial we were not very aggressive about salvaging or getting the disease burden down, as was the teaching at that point of time, that you just keep the disease going, maybe vincristine, 6 MBM takes, and then take them to therapy. So we gave CAR T cell 6 million cells per kg body weight. That was the starting dose for ALL cohort. The patient had fever the same day, required 3 doses of TOSI, steroids, also had gram-negative sepsis. So that's another problem. The more steroids you require in an ALL patient with an active disease, in our context, it's like treating an AML induction. So you will end up with gram-negative sepsis. But fortunately, he attained a CR on day 28, but it was a complicated course. And on the other hand, there was a 30-year-old male who had persistent disease, 15% blast after induction 2, came to us for CAR T cell therapy, got the CAR T cell therapy, had an uncomplicated course, got discharged on day 7. By the way, the first patient stayed throughout the 4 weeks with us and attained CR. He's completed 15 months, he's still on follow-up. So the scenario about ICHS is, this is a 16-year-old male who had relapsed on maintenance. So this is outside the trial. We salvaged him with mini hypersensitivity with inotuzumab. You had a CR, his morphological 7% blast MRD negative. We did the apheresis. We then usually give a 0.3 mg per meter square 1 more dose of inotuzumab while we are waiting for the product, because that takes about 3 weeks. We gave him 5 million cells per kg body weight, discharged on day 4. He had a readmission. So by the way, outside the clinical trial, if the patient is asymptomatic, then we discharge them, and as long as the patient is compliant, and after teaching them after educating them that they have to come back with if there's fever. So He came back with fever, had a grade 2 CRS, was managed with tocilizumab. Subsequently, on day 18, he came back with cytopenia. So this is what happened. This is the ferritin trend. So there was a rise in the ferritin. So it was 10,000. Again, this has to be compared with the pre-CAR T ferritin, because that again could be a little misleading sometimes. But it's also the dynamics, the rise of ferritin, which is important. Generally, we see a very rapid rise, almost doubling of ferritin every 24 hours. So we started him on anakinra, which is again the standard of care here in this setting, rather than steroids and cyclosporin. So anakinra, and then the protocols or the SOPs require that you have to recalibrate very quickly. So 72 hours, there was not much response. So we added the second drug, which was ruxolitinib. Then had a response, stabilized, and then, he's still early though. He's just completed 3 months of follow-up. But this is just to show what can happen in terms of ICHs. Now, in terms of supportive care, infections are going to be always are important for us. This is again a situation where you are inducing neutropenia, T-cell dysfunction, B-cell dysfunction. So perfect recipe for a disaster, but this has to be therefore managed very carefully. So antifungals, the strategy that we use is we give posaconazole till the neutrophil recovery, or we reintroduce only if the patient has cytopenias, like late cytopenias, or if the patient is requiring steroids. IVIG, we follow the standard guidelines. The only thing is we keep a little higher threshold. Instead of 400, we keep a threshold of 600, particularly in the first 6 months. Beyond the 6 months, as long as the levels are more than 400, then we just monitor these patients. Another important point is vaccine preventable infection. Now, this becomes even more complicated because some of these patients are post-allo transplant recipients, partially vaccinated, fully vaccinated. So these protocols are sometimes confusing. So we have modified, adapted. Our ID committee has created a very nice vaccination strategy. So, and this is important because we've had already a couple of patients before the vaccination was in place, the vaccination strategy was in place, one with Haemophilus influenza, one with pneumococcus. So it's not something which is unlikely to happen. This is going to happen. And then I said, as last thing which I wanted to highlight was tuberculosis. T-cell dysfunction means that we have to be watching this. This has happened only in 2 patients so far of the close to 80-90 patients we have treated, but this is something which is going to be very, very important for us. So this just as an example, this 65-year-old male patient who with DLBCL post 3 lines of therapy, got 10 million cells per kg body weight of CAR T-cell therapy. He had a grade 1 CRS, otherwise an uncomplicated course. Required IVIG in the initial 6 months, then was off IVIG, but had 2 bouts of pneumonia. Actually, one of the bouts of pneumonia was Haemophilus influenza, for which he required hospitalization, and but then he responded to antibiotics, and then he's on follow-up. But the thing is that also giving vaccination when the patient is receiving IVIG also becomes a little complicated. So this is something that we need to keep in mind. Now, the next important complication I would want to highlight is the hematological toxicities. And hematological toxicities here follows a pattern. This is actually the data from our own trial on what happened to the patient. So, So these are the median values at every time point. So what we have done is we have plotted the hemoglobin, the platelets, and the neutrophil count, starting from day -1 till month 6. So ignore this on the right side. This is just, we are trying to see whether there is a difference according to the lines of therapy they have received. For the timing, just focus on this. That typically what you will see is that there will be a drop in hemoglobin and then they'll recover. So this early drop generally happens in the first week. This is probably related to the fludarabine cyclophosphamide. But there's a second dip which happens. This is in the 3rd week, and this is a drop in platelets and as well as drop in neutrophils sometimes. So this is the delayed ICAT, and this could be problematic. What we have also noticed is that if you have received more than 1 lines of therapy, then this tends to be deeper and can last for a longer time. In the reported literature, this can be so severe to the extent that you can have a marrow episode, meaning you can have a neutrophil count less than 500 for more than 14 days. So that could be a problematic. Though we have not seen it as commonly, the reported incidence is about 20 to 25%. But that is something we have to be careful about. The hematological toxicity, however, with the product that we have used so far has been quite low. Now coming to the post-CAR T-cell therapy monitoring, this is the 4th point, and this is just one slide where we have summarized what we have done. So we have done on the trial, we did a lot of things. We did cytokines, we did CAR PCR, we have done genomics, etc. But I think it all distills down to this at the end of the day, that in the first month, what you do is, of course, you do history, physical examination, CBC biochem at every visit. But the most important aspects or parameters that needs to be monitored is IgG levels. So your IgG levels, you start from day 28 and then monthly for the first 6 months. If the levels are good, then you do 3 monthly and then subsequently beyond 2 years only if it's needed. B cell count or CAR copy. So one of the correlate of the activity. Some people prefer using B-cell count because it indicates the functionality. It indicates whether the CAR is proliferating. Numerically, you can still have CAR copies, but it may not function as well. So B-cell count probably, but if you have a possibility, maybe both. But what is the, particularly in the context of ALL, this is important that you do monthly, because if you have, for the first 6 months, if you have early loss of B-cell aplasia, then there is a need to intervene. Otherwise, the outcomes are not so good. You do a disease status assessment. That's typically what we do is day 28, and if only if clinically indicated. The other couple of important aspects I've highlighted is vaccination. So vaccination should start right at the time of screening. So influenza is the first vaccine that we give, and then subsequently beyond 6 months. And we need to look at whether the patient is a post-allo transplant recipient or not. And antibiotics, as I said, antifungals till ANC recovery, and cotrimoxazole and Asivir till the CD4 count is more than 200, or at least till 12 months. So lastly, post-CAR T-cell therapy intervention. Here is where the data actually is very sketchy, but I'll just tell what basically is right now available. So theoretically, why there is a need, or why there's a thinking that you can combine therapy, and this slide summarizes it. There are different levels at which the CAR T-cell therapy might fail. So it could be starting with the T-cells. It could be like your T-cell quality might be a problem. Like you have more of, you have less of naive cells, you have more of differentiated cells. So your starting material itself may be a problem. You could have a situation where you have a defective synapse, like you have a tumor microenvironment. So either the cells are not able to engage the tumor cell, or there's a myelosuppressive environment. So I mean, there are theoretically a lot of agents which can potentially affect at this at different levels, and some of them at multiple levels. The ones where we have the data, some data is actually with combination of PD-L1 inhibitor. Yeah, so this is combination of PD-L1 inhibitor. So there are 3 studies. This is the one which is published. There are other couple of them as an abstract. And what they try to do is they try to combine PD-L1 inhibitors with CAR T-cell therapy. This one was interesting. This was a phase 1, small phase 1, phase 2 studies. Phase 1 study, this one. So they gave durvalumab. They gave it 2 time points. So they did an early durvalumab and then the late. So the early patients received 1 before and then at day 7, and then the late the group in the late cohort received it beyond 21 days. What they showed was here that patients who got durvalumab before the CAR T-cell therapy, they had a delayed CAR T-cell expansion. So their toxicities were low, but also at the same time the efficacy was also low. This is more of in vitro data, less of clinical correlation, but this is what was seen. So probably if you want to use a PD-L1 inhibitor, use it after the CAR T-cell therapy has expanded. Now the other studies which have been published in this setting is the use of post-CAR T-cell therapy maintenance, particularly with ibrutinib. This is a phase 2 Tarmac study which was recently published. This was on mantle cell lymphoma. Again, testing the concept of using a maintenance. So they use BTK inhibitor, and BTK inhibitor is known to improve the quality of T cells. So what they did is they gave at least 7 days of ibrutinib before the cells were harvested, hoping that this will improve the T cell quality. And then they continued ibrutinib while the patient was waiting, and then continued throughout around the time of infusion, post-infusion, till month 6. And they stopped only if the patient was MRD negative. So most of the patients, except for 4, were MRD negative by this point of time. Again, a small study, but they have shown that there was an increase in the number of patients who had remission as well as MRD clearances. In the study to the right is the one many of us discuss, and this is the analysis from the UK ALL group. What they looked at is, this is a retrospective analysis, and what they looked at is post-CAR-T failure, post-CAR-T, if there's an early loss of B-cell aplasia, what happens to these patients? So the numbers are actually very few, so you have to take this with a big pinch of salt. But 11 patients got transplanted, 8 got maintenance, and there's no difference, and probably I don't think we should overread here, but they showed that an intervention is required. What I did not show here is that the patients who did not receive any intervention, most of them relapsed. So in that sense, there is a need for an intervention. Which one is something that we can always discuss. So I think yes, that is it. So I'll just conclude here. Thank you so much. Thank you.
Thank you, Dr. Hashmukh. Got a couple of queries, starting from very basic. So first was regarding you decided you had an algorithm where you divided to high burden versus low burden. So is there a cutoff which you keep?
Yeah, 25%. So we take 25% plus. That's variable. Some take us 5%, but we take 25% as a cutoff.
And for the leukemias? For the lymphomas?
So for the lymphoma, it is bulky disease, 7 centimeters. So whether you have a bulky disease more than 7 centimeters or not.
Okay. regarding the vaccination strategy, you said you have at the 28 days you think about it. So what are the initial vaccines which you plan to administer?
So
And
influenza is the, yeah, sorry.
yeah, and is there, so in an allo transplant recipient, we have some cutoffs, so when to start and what's the protocol? So how do you adapt here?
So first was that at baseline, the only vaccine that we consider is influenza vaccine while we are waiting for, while we are screening and then we do the FRSs and all that. Everything else happens post CAR T. Sorry. Starting at 6 months. And then again, so there's an algorithm, I can share that with you. This is adapted, this is actually from the FEDH, but also with little relevant local modifications. But it starts at 6 months and patients get divided into two categories, category A and category B. Category A is those who have not received an allo transplant, whereas category B is the patient who's received an allo transplant and not been revaccinated. So basically depending upon what we perceive to be their antibody status or titer status, and then accordingly we then revaccinate them.
And the third was regarding the use of steroids after CAR T. So where do you place it and how does it affect?
So we use steroids. I mean, we of course use it very sparingly, only when it is absolutely indicated. So I think the two important situations is one is in the CRS, particularly if there's a grade 3, grade 2 where we just give one dose, grade 3 and grade 4 where the requirement increases, and in neurotoxicity where it becomes the mainstay where there's no other way around it. So where it is needed, it has to be done. In the IC hemophagocytic syndrome, we don't use much of steroids. In fact, we have had to, in the 6 or 7 patients that we have treated, we have only had to use it in one patient. That's when ruxolitinib and anakinra did not work. We ended up using steroids. So our inclination is not to use it much, but only if it is absolutely indicated, we give CAR T-cell therapy, and we give the steroids. Studies have shown that it does not hamper, but we really don't know. I mean, we would rather not use it.
Wonderful talk, Dr. Smuk. I just wondered, post CAR infusion in the follow-up, are you checking CAR cells, the measurement of CAR cells in all the patients, or it's like optional?
So we did it on the trial. We don't do it outside the trial. Okay. No.
Wonderful talk, Dr. Hasmukh. I have a query. During the monitoring of the IgG, during the first 28 days, is IgG measured every day? Because they have a long half-life. I mean,
no, I didn't. So I noticed not represented correctly. I meant day 28 alone. So post-infusion and then just day 28.
Okay, thank you. Any questions from the...
Smuk, just if you could clarify this, in your comorbidities that you take, cardiac function, how much value do you give for a CAR T infusion? Have you taken patients with cardiac dysfunction?
So 45% is generally what we look at. We are not strict about it, but 45%, even on the trial, it was 45% was the cutoff. So I have not treated anybody less than 45% so far. I mean, I've actually not refused also because I've not seen such a patient. But I would say about 40-45% is where I would be more safe, unless it is absolutely a low disease burden where I feel that the risk of CRS is extremely low, and maybe think of prophylactic TOSI, those kind of things. But otherwise, 40-45% is where I will safely take them.
Biologically, is there a reason that you will be cautious?
Just for cytokine release syndrome, just the fact that if the patient has a cytokine release syndrome, one of the impact of it is it can cause myocardial depression as well. And that is one. And second is also, if I anticipate that there's going to be a neutropenia and there's going to be more of a sepsis, that those are the two things. But CRS would be more of a concern. So if I have a low disease burden lymphoma, then I may not be so much. I will not be overtly concerned about it. But on the other hand, if I have a leukemia, active disease, and then low ejection fraction to begin with, there I'll be really concerned.
So you mentioned about the burden of disease and CRS. Is there also a connection to the dose of CAR and CRS?
We analyzed that, but we did not find any difference in terms of dose. So we did this in the phase 1 as well as now with the pooled phase 2 data, but we've not seen a correlation between the dose of CAR T-cell therapy versus the CRS, the incidence or the severity of CRS.
Thank you. It was an excellent presentation.
So when we tell regarding the CAR, we always tell the success stories. So what about the manufacture failure in the trial?
Yes.
Was it a big problem?
No. So on the phase 1 trial, we had one patient where we were not able to manufacture. On the phase 2 trial, we were not able to manufacture for another patient. So these are the two patients we were not able to manufacture. out of specification, that means where we were not able to reach the 5 million cells, was another 2 patients. So 4 patients out of the 64 patients for whom we did the manufacturing. That is what we have seen. I think the overall data, even outside the trial setting, has been more or less the same. It has almost been 93-94% success of manufacturing, 6% of failure. And again, as I said, the only ones where we had this failure issue was the patients who had recent bendamustine exposure.
Regarding the same question in the context of vaccine preventable infections, it's basically the auto T cells. The T cell memory cells are going to be there. Still the vaccination is being considered for those patients?
So I think it is. I think it's a combination of factors which are happening. I mean, one aspect is neutropenia. Though the neutropenia in most of the patient is transient, but then some milder form of neutropenia can persist in about 20 to 30% of patients in the delayed form, which might take some time to recover. Secondly, the T cell dysfunction because of the exposure to fludarabine for 3 days. And the third, about the B-cell aplasia, I was saying was that most of these patients are exposed to rituximab. So when we were actually on the trial, we were doing a B-cell count, IgG level, even before the, at the time of enrollment. And what we noticed was that a significant number of these patients actually had B-cell aplasia even to begin with, and low antibody levels. So I think a combination of these 3 factors make it, make them susceptible to these infections.
The BTK, ibrutinib, it's a BTK, which is present only in the B cells.
Yes.
Why in the context of T cells?
Yes, so there, I can't recollect the biological basis of this, but yes, it improves the T cell, it switches the T cells to more of a naive cell phenotype. So that is the way it is supposed to work. I cannot recollect if Prashant remembers, because I think he was also interested in this.
I tried to write a ICMR project on.
So it's there in the TARPA trial.
What I remember of it is that it kind of increases the circulating PD-L1 and also upregulates the CD19 expression on the CAR-Ts as well as the the target population. So that's the preclinical data which is available. That is true for both ibrutinib and lenalidomide.
And Dr. Hasmukh, I have a query.
Yeah.
Now you have mentioned about the off-label use of CAR-T. And you have showed a slide about the secondary CNS lymphoma. And the graph, it was looking promising. So what's the data for that actually?
So we don't have much of our own data because of course we did not do this on the trial. On the trial we would only patient where I can remember we had CNS, some CNS disease was a leukemia, and in leukemia it is still allowed if you have a CNS disease, but with the caveat being that the disease has to be brought down. So you give intrathecal injections, you clear the CSF and then you give. So I have not given a CAR T-cell therapy to somebody with active CNS disease. That is not something which I have done. But I know that other centers, there is some experience, and once the therapy has been approved, even in the lymphoma context, if the disease is controlled, CAR T-cell therapy has been used. But this is very early for us to really comment. And Prashant probably has.
I have a question on your definition of B-cell aplasia. So I looked up the literature. It was quite variable,
yes.
undetectable of 50 or 100. What should we use?
So, I mean, what we are looking at is 100 cells. We'll have to draw the line somewhere. So it's 100 cells. If the B-cell count is more than 100 cells, or if in terms of percentage, if it is more than 1% of the total count or more than 3% of the lymphocyte count.
Okay.
Excellent work, Dr. Hasmukh. So my doubt is regarding bendamustine because it is commonly used in whether it is in indolent lymphoma or mantle, or for that matter even in relapse setting DLBCL. So if somebody is exposed to bendamustine, will say no for CAR T-cell?
We wouldn't say no for CAR T-cells only. So this is little tricky right now because on the trial it was actually easier for me because the element of cost was not involved at that point of time. And we realizing that once now it's come onto the commercial setting, it becomes even more important because if I were to tell them that there is a 30% chance of manufacturing failure and you will still have to pay a part of that cost because the moment the cells are shipped out and the manufacturing process is initiated, there's like part of this cost is already incurred. So that becomes a little tricky for us to counsel. Now, having said that, some of the patients are still willing to take that risk. So we offer this therapy as an option. But we prefer, obviously, we would love to have those patients who have at least 9 to 12 months since the last bendamustine. So I think it is important. Now it's easier probably in the DLBCL context, where what happened was that there was a point where polar BR data came and people started using polar BR, so it became a little tricky. But now I think as the awareness has increased, people are not, at least in the DLBCL, they're not using the polar BR. It's difficult to say in follicular lymphoma not to use B plus R. I mean, patients will be given B plus R in the first line setting. And then if they progress within 2 years, these are the patients where you want to give CAR T-cell therapy. So that is a little tricky right now.
Yeah, hello. And with regard to DLBCL, what is the role of maintenance BTKI? Is there any role like that?
So, sir, so this is something which is being studied. I mean, because that curve is like going down so much to 40%. So, in order to lift that curve up, a lot of things are being tried. One of the things even we have done is, so what we are doing right now is post-CAR T, we either give immunotherapy, nivolumab as a maintenance, or we give acalabrutinib and IMiDs as maintenance, with the rationale that this will improve the CAR T-cell persistence as well. So, but we don't have the data to yet support this strategy. I mean, no solid data yet.
So I'm just doing something for, a specific subset of DLBCL. So we have developed in-house MYD88 and CD79B site-specific mutations. And I'm doing for all DLBCLs before CAR T, and I've used in 2 MYD88 mutated DLBCLs, Akala, and one got a near CR and one a response in the brain. She was post-matrix and I did not want to give more chemotherapy. And now one of those patients, I'm continuing on Akala after the CAR T, and she's tolerating well. So just maybe this subset of MYD8 MCD type, you could consider maybe, but you need more data to do that.
One is for ALL, what's the role of, if the patient is MRD negative at the time of CAR T, you intend to do CAR T at the time of when there is an active disease. So you showed the data for the lymphoma and CR, but is there any data that has come out specific for ALL? They are MRD negative. Second is for ALL again, for the early loss of B-cell aplasia. Is there any particular percentage that you can put that these many percentage patients would relapse?
So for the first question, at least there's more data. I showed that meta-analysis, which is there. It is 1,000 plus patients pooled data from multiple trials. Most of them are phase 2. Most of them were the registration trials of the CD19 CAR T-cell therapy. There they have shown that if your disease burden, if you have a low disease burden, which is defined as less than 5% blast, most of them are MRD negative, and there after giving CAR T-cell therapy, there was durability of responses. So I think it was, though the numbers are few at the end of the curve, but at around 5 years, it's about 50 to 60% is where the number is going towards. So there is data that even in an MRD negative context, you give CAR T-cells, it will still expand and still you can, and you're more likely actually to have durability. And we know that it is also it's going to be a much easier course, because the average duration of hospitalization for the entire process is about just 5 to 6 days. So in terms of delivery also it's easier. Of course, as I said, that for me to say this is the best approach. Another year or so, I think we will have to wait. For the second question, that is the analysis from the UKLL group where they have looked at early loss of B-cell aplasia. There was about 130 patients who were analyzed, where they looked at the loss of B-cell aplasia. Numerically, it's only about 40 patients, and the after the loss of B-cell aplasia, the strategy was very heterogeneous. So 13 patients got transplanted, 8 got maintenance, and then about 8 patients who did not get any intervention. A couple of them got a second infusion. The 8 patients who did not get 8 or 7 or 8 patients who did not get any therapy, all but 1 patient relapsed. So that basically is only the premise on which this concern is raised, that if you have an early loss of B-cell aplasia, you need to intervene.
Nice, Dr. So I just wanted to ask your experience on the primary CNS B-cell lymphomas. So how the incidence of ICANS, is there any difference in assessment, or how do you differentiate?
So primary CNS lymphoma per se, I have not treated a single patient till date with CAR T-cell therapy. So I don't have any personal experience of giving CAR T-cell therapy, because we did not include those patients on the trial. Off-label also, I have not treated any patient of primary CNS lymphoma till date with CAR T-cell therapy. But the data which I was showing was actually a pooled analysis where patients were given both axi-cell as well as T-cell cell, and there they have shown that yes, the responses, the CRs are at least similar, almost 45% plus CRs even in those patients.
Would just like to share 2 two of my experiences, and Neeraj has also probably treated one CNS. I have treated two patients, and one was a secondary CNS DLBCL, and the patient, I told them that it is not indicated for this particular subset, but they wanted to try off-label or whatever, and then we have proceeded and given it. And this patient had some CNS toxicity and still continues to have some somnolence. Just 3 months down the line, is the husband shows me on phone that she's just dozing off sitting and excessive somnolence again, but the I score comes out to be 10 again, always. And but still there's some somnolence going on. And the second patient had flow positivity for lymphoma, but not on the microscopy. And this patient also had that delayed, which I mentioned earlier. So these are the two scenarios where there's something happening. Whatever treatment we did. Okay. So to what I have faced till now has resolved immediately after steroids. So it has not become life threatening. But one patient, as I told, that was comatose, but she woke up after the first dose of methylpred. So the responses have been there, immediate responses with steroids.
Yeah, so I mean, we had I think Dr. Sajeevan's patient was there. So that was like a secondary CNS lymphoma, relapsed as CNS, and then she had leptomeningeal disease, all cranial nerves palsied, and she also had disease in the spinal cord as well. So she had paresis and also cranial nerve palsies, and so she received a bridging whole brain RT, and then we took her up. So actually, we were also very much concerned about the ICANS, whether it will be there. So Manisha was actually making her write handwriting every day, but actually it improved. So for her, what happened was that her disease improved and all the CNS manifestations improved day by day. But then she didn't have an ICANS so far. She's about, I think, 4 months post therapy now. But yeah, she had after the CAR-T, she had a fall, and then she developed an intracranial bleed, subarachnoid hemorrhage, after which also she has recovered. But we were also very skeptical that, because there was no trial data. So, but it was very encouraging, I should say, that that the response has been very good so far.
I would be really interested in knowing your experience of late ICANS or somnolence. Do you see anything like that? Not at all.
I think it's probably going to happen more outside the trial because like patients with CNS disease, we have not treated any of them on the trial. So like even if it's a relatively safe in terms of neurotoxicity, but I think it's like how much you're pushing the bar. Now if you take patients with renal dysfunction, if you take patients with CNS disease, comorbidities, prior neurological problems, probably it is going to come up. So yeah, we have to just keep a watch for this.
I think Rahul is online. Could you connect?
Neeraj, I am enjoying listening today. So you guys continue. Excellent clinical discussion.
I know you are hiding behind, but you have to. We will. So there are so many questions people would want to ask you. We will not force you to do a. He is not. Will not force you to do a talk. But I think, thank you, Rahul, for joining us, in spite of not being in the best of health now. So, yeah, thanks. Thanks so much. You're muted.
Oh, thanks a lot. Thanks a lot. I am enjoying the discussion a lot. So, and I'm missing all the discussion as well in person.
So we were just discussing about the CNS penetration of CAR-T, or whether the CNS lymphomas. There was a question raised about ICANS. So whether there would be how would you recognize ICANS? So in that context, can I ask you a question on the ICANS in the trial data that you have is almost nil, right? And so what could be the reason for that?
Yeah, one of the reason of low toxicity, what we thought earlier was the humanization, and because of humanization, the binding off and on rate, the way our CAR construct bind to the B cell or the tumor cell, that on and off rate is very fast. This could be one of the reasons, but we really do not have a very concrete answer why why this neurotoxicity is less. In some lab study, we have seen that when our CAR T interact with monocytes, they induce less IL-6 from the monocytes. But that could be the reason for low CRS. But for neurotoxicity, we really do not know what could be the reason. But why neurotoxicity happens? If we think about it, the reason neurotoxicity happens because CD19 expression is little less on the endothelial cells or in the brain region. So where your CD19 CAR T goes and binds. Another reason could be because the binding affinity, this on and off rate is high. In our CAR T, when they go in, even if they travel or they cross the blood-brain barrier, they are not binding with that affinity to the brain cell, and that's why they are causing less neurotoxicity. So but these are all speculations, scientific speculations. We do not have a concrete answer yet.
All right. Okay. Thank you. And about the other question which I wanted to ask you is about the HLH, which happens in the delayed HLH. Does that mean that the CAR T is, if the patient develops HLH, okay, does that mean that the CAR T is persisting? Is it more likely to persist?
Yeah. Again, since our data is not that much yet, so we do not have those kind of concrete answer. But whatever the Dr. Hasmukh has seen in many patients, CAR T persistence has been very good in majority of the patients. But specifically in that pool where only 3-4 patients I think has gone under HLH, what happened to them? I do not. I can't recollect that at this moment. But otherwise, in majority of the patient, wherever we saw the CR, majority of them, the good persistence we have seen.
And is the CAR T persistence a better marker? I mean, as per the trial, Hasmukh just mentioned that, but as per the trial, you would have the information of the CAR T persistence, but it's not a service which is available now. The early loss of B-cell aplasia. So which is better?
If you ask me again, we cannot have the very clear answer yes or no in this case. But if you ask me, I would say B-cell aplasia is a better marker than the CAR T persistence, because if you see the XC-cell data versus T-cell, XC-cell do not persist that long. But if you see the 5-year survival or those kind of papers, XC-cell is doing wonderful. T-cell being even 4-1BB CAR was supposed to do good in persistence, but compared to the XC-cell, now I think XC-cell is also doing great. So the persistence story, I have my own personal bias. Is really clinically relevant or not? I think time will tell. Definitely for short term, yes, it is important that CAR should persist, and our CAR do persist. But B-cell aplasia would be better clinical prognostic marker compared to the CAR persistence.
There was some data, I mean, there were some publications on where people looked at the hematogons, like the percentage of hematogons in the marrow, especially after the ALL transplants, and then has it got a prognostic value if you look at the hematogons itself and not the B-cell aplasia?
I wouldn't know that. I think that Hasmukh can answer that clinical question because I have not seen that data.
Even I'm not seeing the data. I'll have to look it up.
Because there was, I think I came across a paper where they've looked at a reinfusion they've looked at reinfusions. So one of the indications for reinfusions was a particular cutoff of, I don't remember the exact cutoff, but I think one of the cutoff they put is they do a marrow and find out if there's a significant amount of hematogons that's like a harbinger of relapse, and so you do reinfusions. So it's curious because you have the MRD, you have the B-cell aplasia, and then you have the hematogons, but most people now talk about B-cell aplasia. So the take-home message is B-cell aplasia on the peripheral blood would be the best.
Plus, I think take the patient early in the clinical management for CAR-T. Don't wait for the last minute, and ensure the disease burden is low. I think two things should be your take-home message today. One is take patients one-line failure, two-line failure. Don't wait till all other options are gone. And then second take-home message would be that treat patients with low disease burden. CAR-T works much better even in lymphoma as well as in leukemia when the disease burden is low. And the lymphoma, I think, is 100 centimeters square MTV. I think that's the cutoff. And for lymphoma, Dr. Hasmukh feels less than 25. Some also feel less than 5 or around 5%. So I think anything less than 25% bone marrow blast, I think you will have much better response.
So, okay, thanks. Any questions, Rahul?
Just one point which I would like to add is that probably, so we always, for many years, we have taken MRD as a categorical variable for ALL. But now, there is literature that, it is being, we are starting to regard it as a more continuous variable. And rather than having cutoffs, any level of MRD, is kind of continuously related to the survival and EFS and OS. So now, with the MD Anderson data, which I think Dr. Swami showed, and we recently, last 2 years we have been trying, and finally we got hold of a kit and we validated our NGS in-house, and we have done 2 patients. Right now, the follow-up, we are calling this test clonotrack, just to mimic kind of the clonoseq or whatever you want to say. So now, what my feeling is that we know that any disease is disease, anything measurable. So rather than going too much into the B-cell aplasia loss, probably it would be a kind of a nicer strategy to follow NGF and NGS both now, because NGF is being done in most centers, many centers now, and you're able to look up, beyond the 0.01, which standard, NGS, standard flow looks at. So if we are able to combine these MRD techniques, and because these may be kind of complementary to each other, and then maybe B-cell aplasia may not be such a factor. And in the CD28 co-stim, CAR-Ts at least, that is not a factor, because they come and go, and they still, even there is loss of, lack of persistence, the relapses don't kind of follow. Just a thought.
Is giving the longer disease-free survival. Even that is the reason. So I wanted to know, because we have a 4-1B, but it is a humanized we are projecting. But is there the 28? Even though it does cause a complication, side effects in the transient persistence is not there. But still, if you see most of the things which is having a CD28 as a construct, which is having a better.
I think, so I speak as a clinician, and probably Rahul will have more insights on this, but I think CD28 and 4-1BB have its own, both of them have their own unique features and challenges, at least from the clinical data. So, for example, CD28 data, if you see for the lymphoma, it seems to be much more better as compared to the 4-1BB data. But if you look at the leukemia, it is little different. The strategies are also different. So, when you look at 4-1BB data for leukemia, so when we say that transplants are not being done as a consolidation, most of the groups who are using 4-1BB CAR are not doing allo transplants, or they're less inclined to use allo transplants as consolidation. Whereas if you look at the NIH group and others who use CD28 CARs, they tend to consolidate more with allo transplant, just because there is a concern that there is going to be loss of the CAR T cells. So it is different, and I'm sure it's not as simplistic as the way I am telling you. There are definitely a lot of nuances here. I mean, the construct, and that's why I said Rahul probably will know better, that construct, even a small thing here and there makes a completely different product. So they're more than what we understand.
So I have a question from Hasmukh and Dr. Rahul both. So as of now, we are not seeing any improved efficacy over and above the 2nd gen cards and the 3rd gen cards. They're not working better. So what could be the reason for that?
This is basically what we see all the time in oncology, right? So what we feel in principle may not actually translate into the real world or in your practice. So I think there are a lot of potential for example, even dual CARs. So there's a lot of feeling that it might work better, but it's not really been shown so far to be superior over just giving a single CAR. And likewise with the armored cars and the suicide gene cars, etc. So we will have to wait and see what happens. I mean, this is all in principle, it all sounds attractive, but eventually when it comes to the clinics is where we really get the answers.
Compared to the single CAR, and dual CAR data doesn't look that great. So it appears like if the single CAR is not working, it's hard to get the patient in remission by dual CAR. So I think field is evolving. Which construct, I think the time will tell us once we do more and more patients. And whether it's 41BB CAR or 28 CAR, both have their advantages. And Dr. Hasmukh beautifully said that 41BB CAR seems very, very good in case of leukemias. Lymphoma also, it is giving very good efficacy. And CD28 is always or in majority of the time at least require the allo transplant, which is not the case in the 41BB. So both, I think there are a lot of nuances. Once we do it, we will learn more and more about it, and we all will have more confidence once we have more data.
Rahul, hi, Sharath here. Couldn't hold myself back when you mentioned, about dual. So I just wanted to just bring up, it's a very nice discussion. So it's really nice to discuss. So, I was having thoughts on what is the role of sequential CAR versus a dual CAR, because I'm just thinking it'll make a little more sense. So your thoughts on that? I mean, purely from a, from a constructive perspective.
No, I think, sir, it's a very, very good idea. Sequential CAR would have its own advantages. Now, at what time you have to sequence? Some people are trying even while the infusion, the day one they are giving CD19 and then you can give CD20 or CD22. So both can work together at the same time. Some are thinking like, let us sequentially first do CD19 and then after a month or after a few months you do CD20 or CD22. So there are again different approaches people are trying in the different settings. What will really work? For example, and there are different type of car. So if there is a car which is a tandem car or the car which is a dual car, same car having two by specificity of the which one is better? Again, everybody has a small data set. So until we see the good comprehensive study, we cannot tell which car would ultimately be a good car. But all these strategies, what you mentioned, sequential could be the better option than and sequential, in my opinion, the maybe like you have done split dosing, right? So maybe first you do the CD19 and then immediately you do CD20 or CD22. So even there are very few clones of CD20, they can be killed right away, and then you get the long-term responses. So I think those strategies are excellent strategies, sir.
So Dr. Rahul and Dr. Sharath, so my question to you again in this context, would the antigen density of your target antigen, help you decide your strategy, sequential, dual? Would it change, you have taken us more than 99% expression of CD19, but in Eliana it was it was 90%.
No, it was not 99%. So we required more than 90%.
More than 90%.
99% is on the pediatric trial.
Fine. So, but would that change?
Yeah, Dr. Prashant, two things. One is what I think, Dr. Hasmukh, what I think Dr. Prashant is mentioning about density, not the frequency. Right? Frequency has to be 100% preferred. That all clones should express CD19 if you want CD19 CAR to be the most effective CAR. But if you don't have, then I think people are having this guideline, at least have 90% of the your malignant has CD19 or something. But ideal scenario, your 100% malignant cells should have the CD19. If you have a clone which even with very, very little, you may have the highest chance of relapse. What I think Dr. Prashant said, density of the CD19 on a cell surface. Again, a different CAR, and that comes to the biology of the CAR binding affinity, which I was mentioning on and off rate, the KD of the binding, how efficiently CAR construct will bind on the cell surface of the tumor cell. So every CAR has different binding affinity. And if a patient has very faint expression or very few, let's say only 100 CD19 copy on the cell surface, maybe those patients would relapse quicker because CD19 CAR will be unable to recognize those malignant clones. So you have to have beyond a threshold, and that threshold every study would have. In our cases, I think 1,000 receptor per cell or something like that, but I'm not 100% sure at this moment.
Thanks, Dr. Rahul. So, Asmuk, I have a question, another question from you. So, I remember you mentioning me once that you were checking retrospectively the CD19 IHC on your lymphoma cohort. Can I get to know something about that?
No, that is planned. It's still not complete.
It's still not complete.
Yeah, that is work in progress. Actually, the lymphoma pathologist is taking the most time of all the biomarker analysis that we are running, but it is still pending.
So do you have any patient, if you know of where the CD19 IHC in your center was negative and he responded to your cell? So generally it is not taken as a criteria for enrolling, or
yes, and we do not
not
actually
even the package insert.
correct. So we do not actively ask for CD19 on the IHCs. Only for the ALL we are very particular about.
Okay.
So Prashant, just to add to that, I think when Immunil did it, so they were actually getting documentation of CD19 on that lymph node biopsy. You actually had difficulty finding some of the centers to do it, but it's a little arbitrary, because it's not God's word that tells you one, yes or no. Second, be using that, will it work or will it not? So there's a little gray there, to be honest.
Understood.
Absolutely.
And one theoretical question is, because the discussion was there,
yes,
if you give both CD19 as well as 22 CAR-T on the same, is there any mechanical competitive, because that area what is on the surface it is happening, for the other molecule to act there is no space, something?
They're theoretical, yes. They're theoretical.
Silly questions,
not silly question at all. These are very genuine concerns as well. So when you give more than one, like CAR T-cell therapy, targeting more than one antigen, this is one of the theoretical concern that they could be competitive. It might interfere with the action of the another. So.
Absolutely. And that is called factory side also, like because of competition, they stop working.
So Rahul, one last question from a production perspective, will it be easier to actually make two cars, 119 and 120 versus making a dual?
What happens when you have a dual car, the construct becomes longer. And when construct is longer, you mean one car has both the specificity, right?
Right.
Yeah. So the car construct become longer, and because the big long DNA, your lentiviral vector production yield goes down. So for CAR-T manufacturing, it is not a problem because only problem is the production of lentiviral vector. But I think the first strategy is better and easier, that if you have a single car, and that's the time I think clinically also it's good, because first day you can give one CD19 and then another day you can give CD20 or CD22. So that I think your strategy is much better.
Okay. Thanks.
Because we are constrained of time, so probably we'll stop here. Thanks, Dr. Hasmukh.
Thank you so much.
Thank you, everyone. Thank you.
Thank you so much, sir. Now we shall proceed to panel discussion by the moderator, respected Dr. Sharad Damodar, sir, Clinical Director and Head of the Department of Narayana Hridralaya in Adult Hematology and BMT, and the panelists, respected Dr. Uday Kulkarni, sir, Professor, Department of Clinical Hematology and Stem Cell Transplant, CMC Vellore, and Dr. Prashant Mehta, sir, Senior Consultant, Department of Medical Oncology, Amrita, Faridabad, and Dr. Hashmukh Jain, sir, Associate Professor of Tata Medical Institute, Mumbai, and Dr. Pavan, sir, Assistant Professor, Department of Medical Oncology and Stem Cell Transplant, Basavatarakam Indo-American Hospital, and Dr. Nikhil, sir, Assistant Professor of Medical Oncology and BMT of Amrita.
The trend of what was going on, it's nicer when we can just discuss across My apologies for not being there. Actually, I had some, emergency. That's why I couldn't land up there. But I was just trying to say that, the next, we're running a little bit late. So the next, say 25, 30 minutes, we'll just get all the panel people's views on something which would be, how practical and relevant it is to kind of do things in our country at this point in time with whatever is available. So that's the intent of trying to, see what we can talk about, especially when it's patient selection. I know a lot of times we don't have a choice, but the patient who comes to you will be the patient who you have to treat. You can't be asking for a patient and say, I will select a patient. But other things we can do a little different is what I thought we'll kind of discuss, and we'll get people's perspectives on that. So is my screen visible? I've said share screen. You need to enable. Somebody, if you can enable screen share. Or if Monisha can, display it from there, I've sent you the PPT. Either way, if I can share, it'll be easier.
Sir, we are sharing from here.
Okay, so something's come up there, right? Okay. Yeah, so that's a picture of me with a patient who's about 1.5 years post CAR T-cell therapy. He'll be a nice goody patient if all your patients were like that standing next to you after 1.5 years, So I didn't choose this patient, he was just part of the trial, okay? So good follicular lymphoma who relapsed came in, and during relapse was eligible to be enrolled and thereby got it. So you can see it's a nice fit patient, perfect, so nice outcome. So it's good if all our patients were like that. Next slide. Yeah, so this is what I was breaking my head on. One is, the panelists got decided by Neeraj, so I was thinking what I should ask the panelists now, So let's see, after this discussion, hopefully we've got questions to ask them and get their feedback. Next slide. So choice. So first of all, what do you mean by choice? So clearly there's data that when you have a lot of choice, sometimes it may not be the best thing. When you have limited choice, you have actually better utilization and utility. Okay, next slide. And finally, it may not really matter, it's patient's choice, okay? Patient is going to decide what he wants done. So if somebody comes with you with some comorbidity, I think that came up in the discussion prior to this, you may have to work around it rather than say that, I'm not going to take this patient for treatment, because that's the scenario of practice in our country. And that's very relevant, and that's why we need to fine tune our choices rather than say that we go and pick the goody patient. Next slide. Okay, so what are the CARs we have now? So we certainly have data now, both what Hasmukh has presented, the next CAR available, both for lymphoma and leukemia, and the CAR-T, which is the Immunil CAR, which has now got approval for commercial use, and that is only for lymphoma. So these are our two options. I'm not bringing in cost at this point in time. We'll say there are two of them available. Okay, next slide. So this is a little review article which is worth reading in Nature Reviews. On patient selection and bridging and lymphodepletion. They've nicely discussed this. I think it's very relevant to our setting to kind of go through, and I'm going to take the gist of points from this so that we put that up for discussion. Next slide. So essentially process is, the first part comes to patient selection, then you've got to generate an effective product, and we've looked at things which can affect that, right from exposure to bendamustine and some of the comorbidities. So these are things which come into play, and also discussion on leukemia, where if your blasts are, not expressing adequate antigen, or if you don't have enough cells. Then some components of bridging therapy, most of the time, it's variable there, and that's a physician's call. And then you've got lymphodepletion, which is most of the time standardized. Next slide. So let me just go on to a few cases, and I'll just take the panel's opinion on what you would do at this point in time. So first case, let me give it to Hasmukh, just to kind of kickstart the discussion. So this is the patient, 52-year-old male, DLBCL stage 3, got CHOP into 6 CR, relapses in 6 months time, and then gets DAP into 3 and gets a PR. I think we've already done some of it in the morning, in the earlier discussion. But your thoughts, Hasmukh, on, this situation, patient coming to you at this point in time? what will you offer?
Yeah. So considering that this is PR, I would offer. I would in theory consider both the options of auto transplant as well as CAR T-cell therapy, but I prefer a CAR T-cell therapy in this setting as opposed to auto transplant.
Right. So, any specific reasons?
Sir, because I find it very difficult to convince my transplanters to take a patient with a partial response.
Precisely.
That's why.
Yeah, so it would have been nice if I had said CR there, because then that would be a no-brainer. But I mean, these are the patients you will get sitting in front of you. You've got a PR now. You want to take that call. You know that ideally you wouldn't want to take for an auto there. If you have this option of CAR. So I will come to a little later on people trying to do sequential both. There's some recently published article there. But that's the general thought process, I think, most of us which would do in the current scenario. Okay, so I agree with Hasmukh's plan. Next slide. So Prashant, the case for you. I'm purposely just putting up a few caveats and then we'll discuss the logic behind all this. 45-year-old male. Now this chap has come with a CNS NHL, DLBCL, RNPV protocol given into 5, then there's residual disease.
So I think in this particular situation, probably some consolidation with the radiation or autologous transplant, probably if he's fit. And I would not think of CAR T in the CNS DLBCL as of now. That is not something I am doing, as of now. But I told that in one patient who was post-auto relapse secondary DLBCL, I did take up, for kind of CAR T-cell therapy.
Okay, so in this situation, you would still keep it on hold. You would still want to do something more, give him the auto, and then take a call on possible CAR T, and wouldn't offer it upfront straight away. I mean, this is an educated person who actually asked, Prashant, to be honest. Okay. So that's why I brought it up as a case.
In this particular situation, I don't think I would offer CAR T as of now. I would use the other options first. But I am, I'm aware that there is some data now that's about a 50% response rate in primary CNS lymphoma, and this is a this is a primary CNS. So there is some data now, and maybe in the relapse setting, and that data is also in the relapse setting. So I would only use it at relapse, not upfront.
Okay. Yeah, I mean, I will put up the article which Hasmukh mentioned, the 128 patients, which is the ASH blood data, where they've actually looked at a subset of both PCNL and the secondary CNS lymphomas, and look at reasonable response rates there. Okay. Anybody else would want to say anything else in this particular one, or you would agree with the...
If it's primary CNS lymphoma, anyway, after 5 cycles of chemotherapy, only 30 to 40% patients are going to CR. There will be 60% patients will have a PR. I think continuing a transplant will be a better idea here rather than changing the plan.
Okay, fair. Okay. Next slide. So I'll give this to anybody. Uday, you will take this 65-year-old follicular lymphoma, BR into 6, so standard, practice, relapsed after 2 years, progressed, DLBCL, gets RCOP into 3 and a PR.
Would take up for an auto, sir. Yeah. If that's feasible.
Okay, so let me say that, 65 is a little of an issue. In our setting, from an age perspective, even if she doesn't have too much of comorbidities with the PR, would you still push, or any thoughts from anybody else if everybody would go the auto route?
So I have a thought on this actually. I would now, because I've not been able to do it much, but now with the clonality available with me, I would go for the clonality analysis. If it is clonally related to the underlying follicular, it's a transformed DLBCL. So then the outcomes are not so good. So now the world is probably moving with some sort of venetoclax based treatment for such transformed setting, maybe when epoch, and maybe also incorporating POLA and using a transplant as a consolidation. CAR T in Richter and in transformed transformed follicular, I'm not so sure of the data as of now. But if it is clonally unrelated, I would take it as a de novo DLBCL and then treat accordingly. Although that situation is not so common, but still clonality analysis should be done, which we generally don't do often.
Yeah, but even going by that data, Prashant, the bigger subset would be the one which is transformed, right?
Yeah, I agree. That's what I'm saying. That's it's uncommon. It's maybe would be less than 10% would be unrelated, but still I would like to do that exercise now when I have it available.
Okay, so you would tend to then go with some additional chemo and possibly look at an auto, or would you think that let's debulk, bring disease burden down, and then give a CAR? Why not a CAR? I mean, I'm asking for the sake of asking.
So for transformed DLBCL, I think the data is less efficient as So generally relapsed DLBCL. That's what I know. At least I believe that is what I've read. And but still, CAR remains an option in this setting also.
Okay, let me put this to Hasmukh also and ask him, would he do a CAR in this patient, Hasmukh?
I would. I mean, I'd consider CAR T-cell therapy as an option because it's residual disease. But at the same time, if so, again, I think the same problem, sir, in this setting that to get this patient transplanted is going to be a problem.
Right.
Practically, what happens in this kind of a setting is we most of the times end up just giving 6 cycles of RCOP in hope that they convert into a CR,
right.
And then observe. But if feasible, yes, I'll consider CAR T-cell therapy as an option as well.
Yeah, so I'll tell you the background here for everybody. So there is this subset of slightly older people who are not really that unfit, but not so fit enough where you're comfortably saying we'll go and do an auto with possible beam. So in that setting, would you then say push if finance was not an issue? Will you kind of get some better remission with this subset of patients? I mean, time will tell, but I just brought this up saying that these are characteristics which you have to look at when the patient is coming to you. Right. The other two cases I'll keep for the other two panelists. So next slide.
Can I share one case like that with you?
Yeah, sure.
There is a young
I'm just using the skeletal just to
There was one gentleman who in the COVID times and was from my hometown actually, and he called me. He lives in Dubai, and he called me up and he said that I have this, I had follicular and now I have this progression. I'm coming to India and to take treatment. He came and then he could not reach me somehow. And then on phone we were connected, and he got a biopsy done somewhere else, and it was a transformation. And I said that please, if you can find a space somewhere in the US and get CAR T-cell therapy, that may actually help. And he actually landed up in a clinical trial with Dr. Swaminathan Iyer in MD Anderson, and he got Lysocell Breyanzi, and he got a CR. He still continues to be in CR. He got the cells in 2021, I believe, and still continues to be in CR. That was a transformed follicular. And now Lysocell probably is the only one which is approved for follicular grade 3s. And so that is one experience, one indirect experience which I had to share,
Yeah. So that's the subset. I mean, obviously, you kind of look at these kind of cases and say that, is it thereby doable? And that's one of the reasons why you say that, okay, you could probably offer some of this to some of the patients who come in, even in that setting, right?
Have you dug out some of the data with Richter transformation, how they do with with transformed DLBCL, how they do with CAR T-cell therapy? Is there a data set, Hasmukh, you're aware of? At least what I have always, maybe some anecdotal literature I have read, which says that it's not so efficacious.
Yeah.
So I
don't know if Hasmukh, do you have a subset of such patients in your data? Because I haven't.
So no Richter's transformation, but we have transformed lymphomas. Yes, we had transformed follicular lymphoma. So I think again in the transformation, the transformed follicular lymphomas tend to do better. The numbers of compared to the DLBCL, de novo DLBCLs were smaller, but at least numerically they seem to be doing as well or slightly better compared to DLBCL. Not from my trial. I'm talking about the other data. But the data with the Richter's transformation is not so good. Yeah, that I agree.
Right. Okay, fair enough.
So
Okay, quickly, I'll just, go ahead, Uday.
So actually, from case 1 and case, I mean, it was pretty clear that in chemo-sensitive disease, auto seems to be superior to CAR, at least based on registry data, with all the caveats of the retrospective analysis, which Dr. Hasmukh alluded to. But even in that analysis, when they looked at early relapses, that means relapses within 12 months, still autologous was superior to CAR T-cell therapy as regards progression-free survival. So in a fit patient who is chemo-sensitive, still makes sense for clinicians to offer autologous over CAR T-cell therapy if it's feasible.
Yeah, so your definition of chemosensitive there then becomes that after maybe 3 cycles you've achieved CR or a VGPR, or at least
even a PR. PR
Even
is
a-
good enough for, and data, even if you apply the Scholar 1 criteria for those patients who have responded, their outcomes are superior. So of course, the caveat being that, they should have responded to the chemotherapy, the salvage.
Right.
Now, the ones they have responded to salvage, that subgroup will do better with autologous with the currently available data. And I think that's what is the difference between the three trials, Zuma, Transform, and the Belinda was that in Belinda there was significant proportion of patients who received salvage therapy. So possibly if you respond to salvage chemotherapy, the equipoise is still is there. I mean, in other situations, of course, CAR-T is superior, but where you have responded to salvage, I think it's still one should not do away with cheaper
No,
options.
agreed. We are not shooting on the auto at all. In fact, it's most relevant in our country, and that's precisely the reason why I brought it up for discussion. That it's nice to talk CAR-T, but at the end of the day, you're more likely to do an auto from a finance perspective and whatever else. So the issue is that clearly, so there's a subset who need to get to that phase where they can get the chemo, tolerate it, and show the response. So I think the fitness and all of that will come in. So a lot of comorbidity patients will get excluded. And then that your best response even with the auto is going to be about 50% of that set of patients. And clearly there is data that if you were in CR versus a PR, you would do better if you were in CR pre-auto. So your the subset which will go on to a cure is better off there. So as you pick and get that better patient, clearly I think then it will kind of equate. But lesser numbers of people from the start will get to that point on the auto arm versus the CAR-T arm, is what I'm trying to say. If you look at it from a number perspective, but clearly in the ones who would show response, clearly there is responsive disease. So hopefully your beam also should do something more than your salvage chemo. You should get a response, and probably you'll achieve CR post-auto, which is what you want. So agree with that, that thought for sure. Okay.
Yes, can I add one? PR, even in PET positive PR, the long-term outcome 5-year PFS is in 40-50 range. So it's not like only if you have CR pre-transplant.
Even
if you are PET positive, you do well.
Okay.
So can I say something? I have one interesting mental pathway which I have been thinking of in the last few months, and so this situation of achieving a CR post, salvage. So because we know that some of these patients are going to land up with delayed cytopenias also, and the T-cell health suffers the more and more you give chemotherapy, and also it will suffer beyond the autologous. If they relapse after auto, the T-cell health would be inferior. So how about doing something and thinking of all this when the patient relapses within the first year, you think of both, and then you leukapheresis both for stem cells and for your leukapheresis for your CAR-T manufacture and send it. If you're not resource constrained, keep both open. And now with POLA coming in, your salvage CRs would improve. The CR rate is better with POLA RIs as compared to RIs. And then if you achieve a CR, do an auto and keep your CAR-T cell thing ready with the better quality T cells which you have already sent for the manufacture. And also your stem cells are there with you preserved. And in case you have post-CAR-T toxicity, your stem cell boosts are kind of useful. So you could actually keep both pathways open at relapse and have better T cells just at relapse. This is just a mental pathway I have. I'm not.
No, I think it's a very, very nice thought, and there's actually a trial with data I will show you at the end of this, Prashant. Where people have actually done both. But your thought of collecting the cells upfront before you go and bang more chemo, I think is absolutely valid. Your quality of cells are better, so clearly. And if you could also do your stem cell collection, for which we are saying some sort of remission would be nicer. But clearly, the more chemo you've given, your mobilization becomes an issue. So getting healthier stem cells plus your healthier T cells, certainly, there's no doubt at all in that. And doing it early helps to the extent that people are now looking at maybe even before you start your first chemo, whether you want to just collect your cells and keep it for CAR and then give your first chemo. I think there's some trials going on even.
Yes, there is genomically high risk subsets they are harvesting, upfront before the R-CHOP starts. The genomically high risk subset here.
Correct.
There is one such trial. Yeah.
Right. Okay. So we'll move on with this. This is just some data on relapse rates in NHL. Just go on to the next slide. Yeah. So again, patient selection there. So clearly this has been discussed. So in the trials they said that it was all at least 2 prior lines of therapy in ECOG of 0 to 2, and they clearly excluded other organ dysfunction. I think this was brought up about cardiac, renal. They didn't. No CNS involvement taken in, and obviously uncontrolled infection, which was what the clinical trial data used. Next slide. And like we already discussed, people are looking at earlier lines, and there is some initial data from in the Zuma trial where you've got higher response rates even when they have used it in a small subset of patients, where as upfront, at earlier stages. Next slide. So disease burden, I think we've discussed all of this. Clearly bringing down disease burden helps, and extramedullary disease again is a worse outcome indicator, and obviously if you've got active infection. And I will go on to the next slide, which again brings in this issue of low platelet, LDH, and people who had which kind of translated into slightly worse outcomes and toxicity. So I'll pause here just to get a feel from the other panelists also on any thoughts on what else you used as possible, markers for, predicting worse outcomes.
So, I'm Dr. Pawan. So
yeah, go ahead, Pawan. Anybody?
So cytogenetics, that's poor cytogenetics, that's the biggest marker, and very early relapse or refractory disease. So these, apart from whatever thing, the disease biology.
Okay. Yeah, I think Neeraj did mention that at the end of the day, it didn't make too much of a difference, but I think there's a point there. If you're saying more aggressive disease upfront, higher bulk, okay. Anything else? These are indirect markers again, the LDH and the platelet count. Comorbidities, anybody else would want to comment there? Because if somebody comes in with some comorbidity, at the end of the day, unless you treat their primary problem, they're still going to succumb. So where do we draw the line?
So Hasmukh, I think so we are little flexible outside the trial. Even in the trial, it was not very conservative, the eligibility criteria, and it is manageable. So it's doesn't have to be absolutely fit. Doesn't have to be an ejection fraction of 60%. But yeah, as you said rightly, that we have to draw the line somewhere. So 40-45% is where we feel we are comfortable taking up the patient. Now again, issues like creatinine, renal clearance. Now we had patients with a creatinine clearance of even up to 30 also allowed on the trial, and even outside the trial we have treated patients with creatinine clearance more than 30. Even if it is less than 60, what I mean to say is that, so even if it is in 30 to 60 category, we have ended up using bendamustine instead of fludarabine. So that is one prime concern at that point of time. So we use bendamustine conditioning. Though there are equal, proponents as well as people who don't believe that bendamustine is as good a conditioning regimen, but there is also data to support this strategy. So that's another aspect when we have renal dysfunction. But the bigger concern for me when there is a renal dysfunction and we are taking them up for CAR-T is that if they develop febrile neutropenia, and then a lot of the choice of antibiotics, etc., gets limited. So that becomes a concern. But I think 30 is where we have so far we have allowed, and we have treated a few patients who had as low as 30. Pre-existing cytopenia. So I think in that sense, now I don't know whether hematotox score will strictly be applicable to our setting, because again that is product dependent. But generally it makes sense that biologically that it is a combination of tumor burden as well as the marrow reserve. And so if you have a high hematotox score, you tend to be more careful. You tend to use early GCSF. Use TPO agonists earlier and things like that. So I think that's another aspect we look out for when we're doing. And to add to what was being discussed earlier, that what indicates that this patient is less likely to do well, particularly in the lymphoma, at least we realized that if somebody is having a very rapidly progressing disease, those are the patients who tend to have more complications, less durable responses. So these are the things that goes at the back of the mind when you're looking at these patients and deciding to treat.
Right, absolutely fair. So I think nice points brought up there by Hasmukh, both the cardiac and the renal. So just to add one more component there. So before you kind of embark on, dosing a patient for CAR-T, would you want to still chase, getting a baseline screening for say COVID and H1N1 or any lung related issues which you would want to screen? in our country. Again, considering the fact that the TB flare-up is something which Haspuk mentioned, which we've also seen in this trial. And that's something I've always raised, that this is something which has not been described, but clearly is relevant to our country.
So the TB flare, just to continue the TB flare discussion. So I think what we were also trying to figure out is there is a way, because in some sense we are inducing a T-cell deficiency in some of these patients. Again, it's not consistent. Not everybody becomes T-cell deficient, but some of them do. And so I was trying to draw parallels and look at the literature from the HIV setting, where now using INH prophylaxis has become a standard of care to reduce the risk of tuberculosis. I don't know. I mean, I've still not been able to conclude it. But at least we know that we have to have this threshold high. And to if so, the moment there is a PUOs, work them up aggressively. Particularly if somebody has had a past history of TB, again we are more aware, and we actively look for tuberculosis as one of the factors. So I think that in that sense, yeah, this we will have to keep a watch out for as we treat more and more patients.
Yeah. So thoughts from the others, Uday, Prashant, Pawan, Nikhil. Because this is something which is very relevant. How much of a baseline lung screening should we do, considering these three? Because there is, data of, COVID post CAR T being more, troublesome and with worse outcomes.
We do a standard chest X-ray and spirometry similar to what we would do for a pre-transplant workup. Yeah.
Routine screening for COVID, H1N1,
no.
TB?
Not.
So we also have not been doing any routine screening for COVID, and in fact, none of our transplant patients we are screening for COVID.
Right.
I am not sure that it has made any difference or not. I don't think so, though.
Okay.
Even we don't know, sir. Then only pre-transplant workup. Yeah, only pre-transplant workup and regular. No COVID testing for everybody. We've been stopped from last 2 years. Yeah, only don't.
I don't think I've prescribed even one COVID test in last 2.5 years.
Okay, that's good to hear. So I'm just telling you from having burnt some fingers in the past, that's why I brought it up. A CT chest as part of baseline. I mean, a lot of them would have had PET for lymphoma, but a CT chest otherwise as part of baseline screening.
Yes, sir. As you mentioned, a lot of the patients would have been evaluated, so chest imaging would have been done with our part of the PET. A lot of them, especially elderly, are at probably risk of some occult infections, maybe even some invasive fungal, or they had past history. So we are doing an intense pulmonary screening, especially for those with the history. As mentioned by the others, detailed evaluation like we do for any transplant workup with the pulmonary functions. In addition to that, they are screening for symptoms of probably TB, but we are not testing right now for TB. And already even the influenza and COVID, all of us have stopped probably testing in the last few years.
Okay. Fair. No, I raised it purposely for the sake of discussion,
One point which I would like to raise here is there was a time when I was not screening so well for the liver disease, but I had situations where I had decompensation of liver disease after, let's say even after Otto I had one case. So I am very particular now, and especially in the INO era, I've started to screen more for the liver, hidden fatty liver, and maybe doing fibroscans sometimes, and a gastro consultation I'm seeking for all of most of our patients. And in fact, the last 2 ALL patients which I've taken for CAR T, both have liver problems. The one who is 64-year-old lady, refractory disease, she's a PH-like, and she had 90% blast. I spoke to her before I took her up, and advanced liver fibrosis and transplant ineligible. Although she is child book A, the prothrombin time is normal, but she has high-grade liver fibrosis. The second patient is another ALL, and he is TP53 mutated, refractory disease, and then also heavily pre-treated with IMO, and also on ATT, he developed ATT-induced hepatitis also, so has significant liver issues going on. So I think liver tox also maybe we should take into account, especially in the INO era. And hidden fatty liver disease is kind of an epidemic in India, So we should look at that probably,
Yeah, so Prashant, I mean, the moment we're looking at INO, I think, all of us, it's a red flag, and everybody is chasing for liver, dysfunction, disease, and getting it evaluated and all that. In the absence of that, so in a routine lymphoma patient, say who's going to get, say, a POLA and something else, where we may not be, I think, specifically looking at it because it doesn't really flag. Maybe, we need to keep a watch. Clearly, in the I know subset of patients in the ALL, when you're going even for transplant, otherwise, I think all of us are looking for that specifically. But I think you raised a good point. I think that's also something which may be worth considering. Right. I think we'll just quickly go on to the next slide, which is that data on the CNS meta-analysis. I just thought I'll just show a few slides on that. Oh, wait. Oh, that's not there in my other projection. Okay, sorry. I missed that. Okay, it's okay. That was the data on that, which I couldn't put in the last minute. Okay, we'll just quickly go on to BALL. We've already discussed quite a bit on what happens at BALL relapse. Clearly, our outcomes with whatever, data was shown at the beginning is in the 20-30% range, I think, even with transplant. Next slide. So a case to, so Pawan, 8-year-old child, pre-BALL, CNS negative, post-induction MRD negative, relapses 1 year into maintenance. Currently, what are your thoughts on what you would offer this patient who would, at this point in time, say cost not an issue?
Sir, fortunately, unfortunately, I'm only doing adult hematology oncology, but anyways.
Then we can give it to somebody else
Yeah,
who's
yeah.
not comfortable. Sorry, I didn't know, sorry. Anybody else
So
willing to
I
take
think
this?
in this particular case, probably we will use a relapse protocol. We tend to use R3, UKLL R3 is what we use at relapse.
Okay.
And then if the patients achieve an MRD negativity, then we take, I would take this patient up for transplant. And, now this, if the patient is not, is chemo refractory completely, then maybe, and also Blina becomes an option. And now with the recent approval in children, that also is an option. But I think our go-to would be some chemotherapy if it is 1 year into maintenance already. So
Right.
and transplant.
And then post that a transplant, which would be either a matched sibling or a haplo, whatever is the donor available.
But if the patient is not achieving MRD negativity with our chemotherapy, then all these options would open up, including Blina, and CAR-T.
Okay. And I think this has already been discussed. Post CAR-T, would you still offer an allo in this patient if a matched sibling donor was available?
You're asking whether after CAR-T would we transplant or not? That's what you're asking? So again, the same finer nuances would come in, because now we want to use NGS and NGF both. I would follow the Bissell dysplasia and NGF, NGS both. And right now, I think I would be inclined still towards transplanting, but I'm not sure that may change also. I'm still not sure. In the pediatric age group, at least the CAR-T alone is showing very good long-term outcomes, at least in whatever data is available as of now. In the adults, I would be more and more inclined towards allografting as a consolidation post-CAR-T. But in children, I am not so sure.
Okay, just as a blanket question, how many of you all are having access and practicing NGS-based MRD versus only flow MRD? Just a quick view from the panel.
So I mentioned at the start of the ALL session that we just validated the NGS MRD a month or 1.5 months back. So I have nothing to say. I have only 2 patients where I have done the baseline clonality, and we're going to do the follow-up now. And when we have data, maybe when we publish and when you have more data set, but that is all information I have as of now. So we do NGF routinely generally, not NGS. Next-gen flow is what we follow. And we are not able to send for the 5 lakhs of test clonoSEQ outside India. I have not done any. So I have no access as of now. We have just started.
Right. Uday, anything happening at Velo?
Currently, we are using flow MRD, sir, for ALL.
Yeah. So that's generally been the practice, that we do. I mean, I think most of us don't have access to NGS based, so you have to take that call based on your flow MRD.
But after the advent of Blina, we have had situations which we are finding very difficult to solve with flow. And especially what my hematopathologist tells me is post Blina, there is a more proliferation of the early lymphoid progenitor cells and hematogones, and there is a real confusion into them because some of these are CD19 negative disease subsets, and they are not able to be very sure whether these are early lymphoid progenitors or these are actually blasts. And also in one particular case, what we found is this was there were cells which were CD19 positive, but they were also expressing the NK cell markers. So there was actually aberrant expression of CD19 on the NK cells, and that's how we finally found out that it was not MRD. So all these situations are now coming up in front of us after Blina advent, which we were not finding earlier. And also at baseline, they have to kind of strategize their LAIPs, to account for the CD19 negative disease and relapses. So that also has changed for us.
Okay. Oh, that's interesting. Okay, that's good. Yeah, right. Okay, good. That's good feedback. Right. Okay. So next case. So I need to just quickly finish now. Just next slide, please. Yeah. So this is okay. Now I'll give it to Pawan. I suppose he can take this.
Sure, sir.
So pH positive. This is the post-induction. So we're looking at one molecular marker here, not the flow. Continued TKI, then post high dose MTX MRD negative, then during reinduction relapses with both flow and BCR-ABL coming positive. I didn't put a number there, but just your thoughts on how you look at this particular patient, adult.
So the typical pH positive early relapse. So probably send for IRMA and start a ponatinib based again a salvage chemotherapy or plus or probably a CD20 antibody inotuzumab or blinatumab, but whichever is easily. I mean, definitely blina will be a better option, and probably take for a allotransplant here. Allotransplant and continue the fourth generation TK as a maintenance.
Okay. Any thoughts from anybody else? Others? Uday and the others? Would all of you all do this?
And give some form of salvage and take up for a transplant after achieving a remission.
So any preferences between just change TKI chemo versus adding INO/blin?
I know if cost-wise possible.
Yeah, so I think when there's higher blast burden, most of us would prefer to go the INO route initially. I mean, that's the general experience of what we've seen. And once you get MRD negativity, if there's a donor, for sure that the allo route is the option. So currently at this point in time, nobody is bringing up a CAR T option.
I have a similar question, similar patient and the question, sir. Same 38-year-old patient, pH positive, had a typical induction with a dasatinib as a PKI. He had a CMR post-induction, and she had only an haplo match and no MUD 9/10, less than 9/10. So though this concept of autologous stem cell transplant still exists, so I took after high dose methotrexate arm consolidation arm, I took over a autologous stem cell transplant, BUMEL as a conditioning. 4 months down the line, she relapses with a T315I mutation.
Oh, okay.
So here, that's the big question. Here, no, anyway, we started a ponatinib and mini hyperseroid. She's again in the second CR2, attending probably an MMR now. Now the big question here is CART or second transplant, haplotransplant. Now we're okay with haplotransplant. Here, busulfan upfront, I'm worried about again a VOD and all those things. Second transplant versus CART. The same patient, but a different scenario. Had not like a transplant.
Good. So Pawan actually changed it to a little more complicated case, which is very good. So I'll ask the other two panelists to now respond. Let's see what the others would do.
So if you ask me, sir, so as I said, clearly there are two different Indias here. So there is one India which is looking at blinatumomab, which is looking at NGS MRD monitoring. I don't have that luxury at my center. In fact, NGS, if you ask me, at baseline as well, if I see 10 patients in my leukemia clinic, I ask for one patient. It is that infrequent. Blinatumomab, I've just heard and read about it. I'm yet to use it myself. So it boils down to what I have at my disposal. Also, the way the practice has changed in the last couple of years, or at least in the last 1 year, is that till about a year ago, we still see about 200 ALL patients in the adult OPD every year, new patients. The moment there's a relapse, the only thing that we are discussing is palliative care till recently. That has changed for us now. And it is for the first time in my time in TMH that we have actually actively started treating relapsed ALL. So that I think has been a difference for us. And to the extent that we have almost treated 30 this year with relapsed ALL. And in fact, actively believing that these patients will in fact do better than some of the AML intermediate and poor risk patients as well. So that has changed. So for me, therefore, that is why, that's where I come from. So therefore, for me, what happens is when I see like this, the first thing in our mind is what salvage. So for me, practical thing is ponatinib plus inotuzumab, because that is something which I can give as an outpatient. In fact, I'm very happy the moment I see pH positive, because ponatinib, even as a single agent, will lead to very high responses in this. And I just want the disease burden to come down. I'm happy to give inotuzumab because it can be given as an outpatient. I'm a little worried when it's pH negative because it's mini hyperseverity, I know, and at least we want to keep them in for a short period. I mean, we're aggressive even there in terms of trying to discharge them early, but it still means about 7 to 10 days of occupancy on the bed. So that is the thing. But the moment they come into remission, then we go for CAR T-cell therapy, because our waiting periods are huge. So most of our transplants, as I've been saying earlier, happens actually in maintenance. So when we start talking about pH positive, it's just purely because of the mismatch that we have. So that is what happens practically. Now, all of this, it's not by, it's just by default all of this is happening, and this gives us an opportunity in the next couple of years to know whether, how this strategy is going to stand against the established strategy. So that is what. So, I mean, the answer is basically I'll get them into remission and then take up for CAR-T. That is my answer.
No, that's a nice perspective, I think, which Hasmukh has brought up, because, this is reality, and thereby we need to discuss what is truly on the ground. And this would actually happen to a lot of subset of patients, which I think is fair. So, Hasmukh, the dosing of ponatinib, have you had any issues? You prefer the lower dose, or you're trying to push full dose?
Yeah, so we generally give 30 mg, sir. We just give 30 mg. We just try to give it for about 3 to 4 weeks, and then do the FRSS. And then as a bridge, again, we give, if the patient is in morphological remission by that point of time, then we actually even come down to 15 mg, because in the few patients I have used ponatinib, I had one CML patient who had like extensive thrombosis. He had a massive aortic thrombosis, bilateral, leading to gangrene of bilateral limb. So once you have had one such patient, it's actually requires more courage to give 45 mg of ponatinib.
Yes, that is truly very difficult. And that's precisely the reason why I've asked. It's not easy to tolerate the full dose of 45. Most of us tend to keep it between 15 and 30. Other panelists, your views on this particular case with the added complication of, T315 down the line, and then, would you transplant, CAR-T? What would you do?
We would give inotuzumab plus a TKI and then transplant once in remission.
Okay.
If we don't achieve remission, then we would consider CAR-T.
And then if the CAR-T gets you remission, you will then do an allo after that.
We'll do an allo after that.
Yeah, fair enough. I think some of that already came up in the prior discussions also. Anybody else with anything else different here for this particular?
So no, I think transplant would be get them into MRD negative and offer them a transplant, because we know that there's a resistant clone. We want to probably change it at a cytogenetic level. So I would definitely offer transplant plus. But if we do not achieve MRD, I think a discussion for CAR-T should be considered.
Okay. So just to add a little more to that, so let's say flow MRD negative, but the BCR-ABL is still showing you a small percentage value there. So what would you then do for that?
We still go ahead with transplant.
Correct. And then add some maintenance ponatinib on the back of that. Would anybody consider doing some preemptive DLI here if you still had some molecular positivity? Uday?
We would probably, we would give prophylactic DLI after, we would taper and stop the immunosuppression early. We would put the patient on TKI post-transplant and consider prophylactic DLI also.
Okay. Okay, there's a role for that. So that's the reason why I asked. So there is some data where it actually helps. Okay, next case. I think the cases are done. We'll just quickly go on to some data on, so this is the data for ALL. I really won't go through all of this because we've discussed quite a bit. Next slide. I'm not seeing that. This is patient selection for ALL. This is one I just wanted to get some thoughts from the panel here, after which I think I'll quickly close because so this came up, so during collection, one is, if there's a 2 to 3 week waiting period for, so for an ALL patient who may be, not very stable with high blast percentage, you would want to be giving some additional bridging therapy. So that may determine, what kind of patient you want to pick there or whether you want to bring it down before you collect. And clearly there is data now to say that if you have higher circulating blasts or, the antigen expression on some of those blasts, it might affect your effectivity of the CAR. I think we discussed some of that in the previous discussion with Rahul. Thoughts from the panel on any of this? Would you look at these things, higher? We did say, Hasmukh did mention a cutoff of 25% for some of his patients from a collection perspective. Some people use lower of 5%, saying that let's bring it down before we collect. So thoughts from the panel, anybody can start.
We now we did collect the cells when the patient had very high circulating blasts at the beginning of the trial. And then we give some bridge therapy in between and then infused even with active disease. But yes, looking at the data now, more and more we feel that we should collect, because the sense is that you will have exhausted T cells when you collect with the presence of circulating blasts. So that's one. And from a practical perspective also, even if there is a 15, if you look at most of these trials, 15% of the patients will drop out between the collection to the infusion, and that's mainly because of progression or infection. So even if there's a 15 to 20% possibility that this patient may not end up getting a CAR T-cell therapy infusion, it adds to the finance. It is, for us, logistically, it becomes a very big challenge, because raising funds and then losing 15 to 20% of patients, basically, so we are losing resources. So from that perspective also, we feel that disease burden has to be brought down before we embark on this.
Right. Very good. Right. Thanks for that, Hasmukh. I think very relevant there. Anybody else's thoughts on this? Because this is a genuine issue, which all of us face when you land up with the patient. That's why it's part of patient characteristic.
Add to what Dr. Hasmukh is saying. So this whole bridging period for ALL is absolutely not so simple, and it's going to be very nuanced, and many factors will come into play. Because if you're going to use something intense, if you, let's say, somebody who has already received tons of INO and has liver tox already, and you don't want to, you don't have simple treatments, or you don't have targeted drugs to give anymore, and you have to give some chemotherapy, then maybe you will jeopardize their chances to get to the infusion in a fit shape without any infections, and so you have to take a call on how intense you're going to go. And maybe for some of these patients who have, the kind of patients we are taking up now for CAR T-cell therapy, for them probably it is one of the only hopes of cure. So probably you're going to try to get them to the therapy, as much as possible, rather than jeopardizing their chances in between those 2 to 3 weeks which elapse till the cells are ready.
Right. Yeah, it's a point. We've also, I think, burnt our finger with one such patient where, between collection and the day of infusion, there was a big jump. And then, that translated into a higher CRS, ICANS, and becoming extremely sick. So that's something which we need to be aware of in the ALL subset, that you need to keep that disease burden as low as possible at the time of infusion, to kind of cut down on some of the complications which come up post that.
I can share one of my early experience with one patient, which I'm just treating right now. And it was a very difficult situation, 64-year-old elderly, old lady. And this is a refractory ALL, pH-like. And, before, harvest, before leukapheresis, she had got, all kinds of different treatment, including, HCVD and venetoclax, and, some other chemotherapies. And now she had 30,000 count and 93%, 94% blasts in the peripheral blood. But still, because it is very difficult to, do something more to control the disease at that particular juncture, we went ahead with the leukapheresis. And subsequently, we gave some steroids for 3-4 days, and I tried oral cyclophosphamide because I did not want, because she was so stable otherwise, ECOG PS1. I did not want any infections before the CAR T infusion. And then thereafter I gave her, because her counts were, doubling every 2-3 days, and it reached up to 70,000 or so. And then, I felt that some treatment will be needed now. And I gave Ara-C, 75 milligram per meter square, like you'd given 1B of BFM. And I gave for 3 days, and the counts dropped to 3,000. And subsequently, because within about 20 days we got the cell product, so by that time she had about 50% blasts, and the count was at 2,000, 3,000, and at least she did not get infected and did not get profoundly neutropenic, and sick. So she was able to tolerate the fluci, and then she became profoundly neutropenic. The counts went to 0. She had severe CRS. I had to give TOC thrice, and now she is day 11 or 12. Day 8 PBMRD I was able to do with flow, and that's at 0.06%. The CAR T are proliferating rapidly, despite the leukapheresis being done at a 30,000 count. So this is where I am with this patient as of now, but day 28 result, would come.
Yeah, right. Yeah, good to hear these experiences, Prashant, because these are actual realities. Right. Okay, we move on to so I did discuss about these issues which have to be kept in mind. Okay, so these are things which we need to factor in, especially in ALL patients at the time of collection. And that last line there about a prospective donor being available in some subset of people where you might want to piggyback an allo transplant once you got the MRD negativity, because that sometimes doesn't stay long and you would not want to miss that window. So that's one of the things when you're looking at patient selection for ALL. Next slide. So maybe one last few thoughts on lymphocyte count before collection. So as part of clinical trials, some people have used these cutoffs, which are mentioned here, of an absolute lymphocyte cutoff and CD3 positive cell count cutoff. I don't know, maybe this should actually get addressed to either Hasmukh or Rahul's team on whether they're using any of these criteria beyond the trial, where you want to see the lymphocyte count before you go and collect. Thoughts from anybody? And if Rahul is there.
So roughly we look at we tend to keep that number in mind, that absolute lymphocyte count should be around 500, but we are not very restrictive about that. So even if the lymphocyte count is as low as 300, we still do. Just because this 500 is actually it gives us a little bit of a buffer that we are trying to collect 2 billion lymphocytes. So that's why it's 500 and above. But even if we are able to collect 500 million lymphocytes, that is sufficient to get one product. So it's just that we will not have a backup, or if there's too much of a cell loss, then there is a concern. So that's the thing. And again, some of these cases, what we have done is then we've done a second round of apheresis on the second day in very few patients, and we've been able to get the yield. So, sir, we use this as a guiding, like a guiding
number, but not absolutely stick to. Fair enough. I think that's a general thought here. Next slide, please. Yeah, so bridging, I really want to go into too much of this now because we've already discussed so much. So all three options are there: immunochemo and radiation, and we'll just quickly run through these slides. Next slide. So bridging therapies are different for the NHL and the ALL subset. There are examples of all of this. Go next slide. Next slide. I just want to run through quickly. Next slide again. These are just examples of what all is used. In ALL, again, we've already discussed. Next slide. And some of the lymphodepletions. Yeah, I'll just come to this article and I'll end here, because it's just running into too much of time. So this really already came up for a possible discussion. Combinational therapy of CAR-T and auto, demonstrating improved efficacy in the relapsed refractory B-cell subset. Next slide. So this is about 25 patient data, and overall response rates 92% and 72% respectively. So the overall response and the CR rates, and the 2-year progression-free survival here in this setting of relapsed refractory, 62% and 68%. At about a median follow-up of 27 months, which is pretty impressive and seems to be better than the CAR-T subset alone or the auto subset alone. So there's a little bit issue of combination, and I'll show you what they actually did. Next slide. So this is the protocol they use. So like Prashant mentioned, why not collect both? So they've done that. They've collected stem cell and then done the leukocyte apheresis for CAR-T. Then you do a salvage bridging, okay, and myeloablative conditioning and put in the stem cell. And then 3 days later or 2 days later, you put in your CAR-T and then just follow up. Clearly, there's a lot of cytopenia, thrombocytopenia infection described, but really didn't translate into too much of trouble in this particular subset. Next slide. And this is the results, okay? So you've got your CR rates of in the 70% range. Everybody's responded here. And 20% PR and stable disease. And this is pretty impressive if you looked at as a comparator, even though it's a small number of patients. So people are even beginning to think on these lines of trying to combine both and see whether you'll actually translate into better long-term efficacy. So just a thought to just kind of close. I've got more slides, but I'm not going to go at it. We've really taken a long time to discuss this. So I'll end here and thank you all the panelists for your great inputs. It was a really nice chat. And thank you for your time. And I'd like to thank Neeraj for this invite. I'm sorry I couldn't have come there. I would have been happier if I could actually be there. But I think we'll end here.
Sharad sir, one question can I ask? This is about patient selection. If you have a patient, basically in the lymphoma cohort, like if recently there was a paper on the metabolic tumor volume. Mentioned. So is there any patient that we shouldn't let's say patient comes less than 12 months relapse or primary refractory. Based on metabolic tumor volume, would you say this patient should not be selected for CAR T?
Yeah, I've actually had some discussion even with the PET people on this, Neeraj, because some of them were involved in the trial assessment also, to kind of tell us whether you can give us a number on that and tell us, this chap is not going to do so that well, or he may not respond, but it's not there, it's still in data and collection. People are trying to draw these lines. So leave alone for CAR T, even for your other, salvage chemo response, we don't have clear-cut guidelines and cutoffs there. So that's where it stands now. I mean, if there's anybody else who has anything else to add, I'm happy to listen to. But clearly, I think we need a little more data on how this is actually practiced, right? From its measurement and the documentation of what is your baseline and what it is post-treatment, and whether you can use that truly as a marker for response. So as of now, I think it's a little open there. If anybody else has anything to add to that, I'm happy to listen.
Rahul has mentioned the tumor volume of some 100 something cutoff he has mentioned in his talk when he was giving that measurement.
Yes.
Value of cutoff 100, but it is not a negativism, but the success rate may be less.
Yeah. So
my question is, in the third case, we always concentrated on the PR rate and the consolidation with the CAR T or the transplant. Third case, 65-year-old male. When we say, keeping aside the geriatric assessment comorbidity index, 65, is there any senescence of the T cell which is influencing the CAR T per se, or it is because generally when we say that CAR T as the age increases it will be less? We know the stem cell toxicity, autologous consolidation, but whether the senescent senescent T cells are having a negative.
So first is that metabolic tumor volume. What Dr. Rahul was alluding to was that once you have this trial and then you do the subgroup analysis trying to find out which patients would do better versus not. So the cutoff that we draw was metabolic tumor volume of 100, and the ones who had more than 100, the responses were less compared to the those who had more than 100. But having said that, as Dr. Sharath said, that there is no magic figure yet. We don't know that number. These are all the things, these are all the biomarkers that we would love to have, particularly in these kind of therapies which are expensive, can have complications, but we don't have that number yet, where we say that, okay, we will not, or we say that we need to do something else. That's first. And second is in terms of senescence, we have, I have to go back and look at this from this perspective now, that age cutoff and whether there is a difference in terms of, so what we have is we have the complete data of the FRSS product as well as the CAR T product in terms of the T cell subtypes. So how many of them are naive, how many of them are memory, how many of them are effector. I don't know whether Dr. Rahul would have that information, but I do not actively look for this. But having said that, this is very variable. This is also related to the lines of therapy and other aspects also. So the 80-plus-year-old patient whom I'm treating has the best T cell profile that we have seen for quite some time. So, but I don't know really what is how it pans out.
I'm also not aware on that data.
Because generally the concept is when the more than 60, as the age increases, the CAR T is also having the bad outcome. Generally,
the responses are more or less similar. The toxicities are a little more. Yeah.
The second question.
Yeah, that's why the comorbidity comes in from the auto perspective, Ramswamy, versus here where you're still able to push. Which even on trials you'll see 95% of people got the CARs, whereas in all the three trials, only about 50-60% of them actually went on to the arm of auto and received it, which is why one of those disparities has come up with with some of the studies.
Absolutely, because there is no high dose chemotherapy, so definitely you can play around for controlling the disease. But 70, after the age of 60, most of the trial says that it is not, we say the senescence of the T cells is a cause. The second case is the fifth case where that pH positive cases, you mentioned that flow is negative, whereas BCR-ABL is little bit of positive. In that case, Asmukh was trying that CAR T can be considered. The BCR-ABL mutation can be there in the T cell also, even though it is a CM also. In that case, it may affect the outcome. Your views?
So even if this T315I mutation, it is still used, CAR T-cell therapy is still used. Now what to do, whether it is after post-CAR T, what to do in these patients is something which is being explored. Now one of the things, of course, better studied is using consolidative allotransplant. But even where allotransplants are not being done, in fact, there are 2 Chinese studies which have come. Their trials are very radical, like what this tandem, like the other trial which Sir just showed. So they have done just VCR, steroids and TKI induction. This is de novo ALL VCR steroid TKI induction, CAR T as consolidation, and post CAR T just TKI as maintenance. So no transplants, and they have done this and have shown that there, I mean, in whatever small numbers that they've published so far, they've shown that the results are remarkable. So this question whether you could give post CAR T TKI is an open question. There are people for and against it as well, but more and more people are accepting that you can use TKIs as post CAR T maintenance in this context. So.
Right. Anything from Uday, your last thoughts, and then we close, Uday. We're all running really late.
So I think from the MD Anderson Cancer Center, there was a publication on tumor metabolic volume in patients who were in PR. I think higher volumes affected the CAR T outcomes, whereas that was not true for autologous. So that's one thing that one should.
But was there a cutoff there, Uday? I also don't.
Some 12 ml. So I think it was a median that they used, 12 ml as the cutoff for the tumor metabolic volume. But I think that may vary. But the message is, I think if you have bulk disease there, I think in patients who are in partial response, probably better to.
No, that is recommended to debulk anyway as you're bridging for sure. So that's there. So do we then have something to kind of draw a line? That's the thought.
Higher tumor volume probably is worse for immunotherapy.
Okay, right. So I think that's it from our end. Neeraj, I'll hand it back to you, and thank you for your time, and thank you everybody.
Thank you, sir. Now we shall have the last session of talk by the speaker, respected Dr. Nikhil Krishna Haridas, sir, Assistant Professor of Medical Oncology and BMT Amrita, on the topic Future of CAR T Beyond Hematological Malignancies, chaired by respected Dr. Sajeevan, sir, Head of the Department of Medical Oncology, MVR Cancer Center, and respected Dr. Matthew Thomas, sir, Senior Consultant and Professor of Department of Internal Medicine, KIMS Hospital, Trivandrum. So I request respected speaker and also the chairpersons to please come on to the dais.
Good evening all. I will keep, since it's the last session and we are running out of time, I'll keep it as brief as possible. You will understand also at the end of the talk why it is as brief as possible. So I just, slide changer. So we know CAR is one of the immune therapy mechanisms. In oncology, we have the monoclonal antibodies, ICE inhibitors, we have the BiTEs, we have TIL. I would just go back a little bit to a history to keep this interesting, otherwise it's a very boring topic. We know that the immune cells by both Eva and George Klein in 1960 showed that it can kill cancer in mice, and the mechanism was not understood at that time and exact cells involved was not understood. Then of course we have the bone marrow transplant from Memorial Sloan Kettering, where they use unrelated donors to replenish a patient's blood cell after intense chemotherapy. And finally we had the Steven Rosenberg and the group in 1986 who used TIL to treat a lot of metastatic cancers of multiple, different advanced and metastatic cancers. And there was some response, but it was not a durable response at that time. We know that they started the development of the first gen CAR in 1993. You can see CAR has come a long way forward. You had the Israeli group also do the CAR. Then you had the second gen, which probably led to CAR being little more mainstream and better responses in B cell malignancies. And we have reached, you can see in 2023, probably there are trials for mutated c-KIT CAR to be added to treat solid tumors which have c-KIT mutation in them. And of course, non-malignant indications also. So first I will talk about the common trial. A lot of these trials are phase 1, phase 2, none of them are phase 3. What are the common target antigens that are used when we develop a CAR T? Like we have a CD19, established and almost universal target in B cell malignancies. Unfortunately, there are some common things. We have one thing called the EGFR and the EGFR variant growth factors. This is seen in GBM. GBM is one of the solid tumors now targeted for CAR therapy. There is enough trial that intrathecal administration of EGFR do lead to responses in patients who have with glioblastoma with almost a response rate and median survival of 8 months post primary treatment. It has been tried in non-small lung cancer, but it is not that effective. Coming to the another tumor marker is the interleukin 13 RA2. This is associated with diminished survival in GBM. It is effectively this specific CART, if you develop them, it can effectively traffic the cells to brain parenchyma from the peripheral blood, especially in the tumor regions. So this is very interesting. Trial done with the IL-13 CART had a good response. It was instilled in the operative cavity and there seems to be a promising response. The trials are attached below. The only thing is that it seems, the local control was probably offered and it was not sustained. Patient had a relapse in another site. This is the UPenn, the Bruce team where they had a dual CAR-T, both EGFR and IL-13RA CAR-T, which was instilled intrathecally. And you can see day -1 imaging and the day +1 post-CAR-T imaging. That is a dramatic response for a patient with a relapsed refractory, with a relapsed disease. Again, commonly other study thing are mesothelin. Mesothelin is seen in ovarian cancers, pancreas, lung, triple negative breast cancers, etc. So there is mesothelin has a very poor mesothelin based CAR-T, a very poor persistence in mixed the tumor microenvironment in all these trials. At the most, they showed a stable disease when given, and usually they require probably, as we discussed, some immune checkpoint inhibitors to probably enhance their effect. Again, HER2 seen in both breast and gastric cancers. The studies have been done with the HER2 and CMV linked bispecific cytotoxic T-cell lymphocytes, while the treatment at the best got a partial response with 9 months. All these are phase 1 to phase 2 data only. Again, in prostate, PSMA is being targeted. There is other ganglioside, mucin 1, I'm just going to run through it. And NKGD2 is another effective target for solid tumors. The other targets are being Claudin 18-2 in gastric cancer, CEA, Glycan3 for HCC. A Chinese trial is ongoing showing some early promise. And none of these probably have shown that dramatic response what we were hearing with our lymphomas and leukemia, B-cell lymphoma, leukemia. That is right now where we are at, with the exception of probably the dual CAR-T in glioblastoma. Probably that will be one of the earlier approvals. Now, what are the obstacles? Generally, the access to the tumor site, unlike lymphoma, leukemia, where the peripheral infusion does, the T-cell trafficking is good. That is lesser in our patients. Of course, large tumors, hypoxia, metabolic impairment, etc., all the lactate, indolate, all play a role in the CAR T-cell efficacy and reducing it. Of course, tumor heterogeneity, all the cells may not have our target antigen. And a lot of the tumors are cold and very immunosuppressive microenvironment. And so hence some few counter strategies are done to enhance, which I am just going to run through. Probably some of them include like overcoming the tumor heterogeneity by trying multiple CAR-T, a mixture of tandem CAR-T or dual CAR-T. We already discussed about this in context of a B-cell DLBCL as in Sharat sir's talk. even counteracting the tumor milieu by antibodies for Treg depletion, inhibitory cytokines, etc., can be used. So these are the probably measures which we use to increase the homing penetration, direct injection to the tumor, implantable biopolymers, CAR-T expression, expressing chemokines. You have the trucks also, which are supposed to be multi-cellular. Trucks are the cart with the universal cytokine release. To improve the tumor heterogeneity, we have already spoken about maybe getting a universal target like mesothelin, smart cart, multi-cart, combination with a BiTE or a immune checkpoint inhibitor, tumor microenvironment modulation with the checkpoint inhibitor, with also armored cart, targeted cart, etc. Or a combination with the oncolytic virus as seen with CMV. Of course, for reducing the toxicities, we have to use stop CAR, go CAR, or a suicide switch needs to be integrated. Probably the 5th gen CAR, we may come up to that technology. So, to summarize the current scenario, CD19 CAR is probably like a Bugatti, and for solid malignancies right now, we are still in a bullock cart type of scenario. Is the future promising? I think the combination with the CRISPR, even probably the commercial use of a CRISPR gene editing tools probably will help and improve. And as more and more research is thinking, and more this thing, they will be able to reduce cost. And with that, so we are still in a very nascent area when it comes to solid tumors. Hopefully the future is exciting and will be accessible to all. With that, I would like to thank everybody for the patient listening.
I think what he has told is what is going to happen in the future, but I saw that the glioblastoma, the MRIs were so good that it immediately solved the whole thing. But the worrying thing was it came back in the same way. That is what we found with the glioblastoma.
Yes, so there is relapses, so there are multiple factors. We don't have the durable response.
But that pictures were so brilliant.
Right now we have data with 80% response rates in all DLBSL and even leukemia that is not sustained in any of these trials.
Last year, we at our center did TILS for one melanoma, metastatic melanoma, post failure of immunotherapy. She had Tommy course. She had a tumor response post TILS, but she had a severe cytopenia and died due to a fungal septicemia. So, very stormy course. Multiple
melanoma is one of the first diseases to even historically in the I think late 89s also to use TIL. And we know that immunotherapy, melanoma is an immune-rich environment.
This patient failed immunotherapy, failed multiple line. Actually, while taking transplant, she had extensive GA disease, extensive bleeding and all. She had a transient period where the disease was in remission, but then died due to sepsis.
The responses are not sustained. It's just as simple as that. Multiple factors are discussed. They are trying to overcome it, but as of now, even trial, the results are not very impressive. Even though radiological responses are there, it is not sustained.
I think if there are no more comments, we can wind up. Thank you, Nikhil, for taking us through the
Thank
glimpse
you,
of that in the evolving field.
Thank you, sir.
Thank you.
So, concluding the session, so my heartfelt thanks to everyone who has been here, especially the chairpersons and our moderators, Dr. Ramasamy sir, Dr. Matthew Thomas sir, Dr. Sajeevan sir, who had come from MVR, Dr. Prashant Mehta, come from Delhi to join us on the occasion, Dr. Sudeep, and our other speaker, Dr. Mukh. So, it was a wonderful discussion today. I know that I learned a lot from each and every one of you, and of course tiring as well. And I see only very few of you are remaining here. So anyway, in the years to come, I hope this treatment and some light we could achieve today, some depending on the discussions that we had, to where we can hope to treat many more of our patients with currently better treatment options that is available. And I would also thank the Immunart team for helping us organize this wonderful function. Thanking you. Thank you.